who has actually come through the long distance for highlighting the house of the symposium, the VERTIGO, and I welcome our faculties actually from the different departments too, and delegates. Actually, the symposium, CMB conferences, all is actually dependent upon the delegates. I welcome you all to this symposium of the VERTIGO. So we all know this equilibrium is an important part of our all life. So if our balance, disturbance is there, we are not able to stable ourselves, and we can then the mood disorders and then our own behavior changes if something happens to our body. So in this presentation, we are going to deal with the anatomy and the physiology. Not working. So, the vestibular system, yes, the vestibular system is in our inner ear. So, the inner ear is composed of the bony labyrinth and the membranous labyrinth and the cochlea. So, main the labyrinth and the cochlea. The labyrinth is the part where that vestibular equilibrium it controls, whereas the cochlea helps for the hearing part. So, vestibular system is the organ of balance and equilibrium located in the inner ear. It maintains the posture, sacral orientation, that is proprioceptive receptors, eye stability, which is the OVOR, that is the vestibulo-ocular reflex. We all know about the structures which are actually there in the inner ear, and balance is the main thing. So, the vestibular system is again divided into the peripheral and the central system. When we are talking about the peripheral, so there is a semicircular canals, and there are two sensory organs, the utricle and the saccule in the labyrinth itself, and which measures the acceleration, the movements of the acceleration of the head, and rotation by the three semicircular canals, anterior, posterior, and lateral. So the linear movement or the linear acceleration by the utricle and the saccule. So central vestibular system having the four vestibular nuclei and gives projection to the thalamus, cortex, cerebellum, and descending spinal cord and the extraocular motor nuclei muscle. So in the inner ear, we all actually see this inner ear is internal ear that consists of irregular sensory canals, and the cavities is actually comprised of bony labyrinth and the membranous labyrinth. Vestibular apparatus, it lies actually along the vestibule and the sensory canal. So the body labyrinth, yes, it is the outer chamber or the membranous labyrinth, and this body labyrinth has the vestibule, central chamber of the labyrinth, in its lateral wall lies the wall window, semicircular canals and the cochlea. So there is in between the membranous labyrinth and the body labyrinth is the perineum. So the membranous labyrinth as having the cochlear duct, utricle, saccule, three sensory canal, and the endolymphatic duct and the sac, which actually get enlarged during the Meniere's disease. So the sensory canals, as this picture is showing, that all the three sensory canals they actually lies at the right angle to and the perpendicular to each other. So anterior is also called as the superior central canal, posterior central canal, lateral is called as the horizontal central canal, which arrange perpendicular to each other and opens into the utricle, which is having a sensory organ, the macula. And this we can see the horizontal central canal is at around 30 degree when we are at active state, and all others are all lying to the right in terms of perpendicular to this. So when we are talking about the utricle and the saccule, so these are actually present at the ampulla end of the sensory canal, where that enters into the vestibule. That the utricle at posterior part of the vestibule, and where the five openings of the sensory ducts, and the sensory part, sensory organ is the macula. So also the utricular duct, and it is responsible for the horizontal movement. And where the saccule, it lies anterior to the utricle, opposite the stapes plate in the bony vestibule, and saccule is connected to the cochlea via thin reunion duct, and it is responsible for our vertical movement. So this is a small video in which we are going to see.
The vestibular portion is made up of three semicircular canals. Each canal has a swelling at one end, the ampulla, and two membranes. The ampulla and two membranous sacs, utricle and the saccule. These contain fluid and sensory cells, which move in response to head movement and travel to indicate the body's status. The vestibular system works in conjunction with the eyes and the receptor cells in the joints of the body to continuously maintain our balance. The cochlea appears as a coiled tube in the shape of a snail shell, with between 2.5 and 2 3/4 turns. It is wrapped around the acoustic portion of the auditory nerve. If we were to unravel the cochlea, it would be about 35 to 40 millimeters long.
So the movement of the pectoral membrane, outer air cells.
It is split into three distinct sections, known as the scala vestibuli, scala media, and scala tympani. The scala vestibuli and the scala tympani contains perilytic fluid. Scala media contains endolytic fluid. The Weissner's membrane separates the scala vesticuli from the scala media, and the vascular membrane separates the scala media from the scala cutanea. Along the vascular membrane are two types of sensory cells, or hair cells, called the outer and inner hair cells. These are arranged in their rows according to the frequency, or pitch, of sound they detect, and covered by the tectorial membrane. Each hair cell has tiny hair-like projections, called stereocilia, attached to them. When sound energy is transferred to the cochlea, the vascular membrane vibrates up and down, causing the outer hair cell stereocilia to shear on the tectorial membrane above. This shearing action causes the stereocilia to bend, which opens the iron gates, leading to chemical changes and a resulting electrical charge inside their cells. These charges make a neural impulse, which travels along the auditory nerve to the brain, and which is interpreted as sound. This complex mix of physical, chemical, and mechanical processes occurs almost instantaneously, and creates our perceptions of the sounds we hear in everyday life.
These are the
The
signals.
brain, and which is interpreted as sound. This complex mix of physical, chemical, and mechanical processes occurs almost instantaneously, and creates our perceptions of the sounds we hear in everyday life.
So, these crista ampullaris and the macula, which are actually present at the ampullary end of the semicircular canal, and in the crista part, we are able to see the nerve fibers which are attached to the hair cells, and the capula. When the capula, so this is a stable stage. So whensoever the process, the movement of the head occurs, the capula it moves towards the horizontal or the vertical part, and thus the balance starts. And another one is the macula. So we can see this is a caniculum cells, the longest hair cells, cilious type 1, and having the gelatinous membrane, and there is otoconia. By the shifting movement of this otoconia, it towards the direction of the movement and starts. So this is the same picture in the later. Now coming to the physiology of the semicircular canal, it detects the angular acceleration and the horizontal canal side-to-side movement, anterior nodding and the posterior tilting. You can see in the picture how the flow of the endolale, which is causing the movements of the acceleration, and see how the hair cells they are going to move. So in this picture you can see how the movements are started. So these are the otolith organs. So little bit about these hair cells. The numbers are much more in the macula part. It is in the thousands, around 60,000. So these are the hair cells of two different types, flask and the cylindrical type. So how the inner ear is balancing system. So this is a small video by which you can appreciate.
Deep within each ear, good. The camera system called the labyrinth was of three semicircular canals. These semicircular canals are all connected to the cochlea, which is organs and allows for hearing. Each semicircular canal is responsible for sending energy to other direction. Each semicircular canal is filled with fluid, and with the displacement of the fluid occurs within the canal, nerve signals that send the brain to officially side to side in no motion.
So the vestibular nerve and the ganglions. So these are the pathways by which the accelerations occur. So due to the lack of time and little bit disturbance of this audio visual, I have to. So these are there are these receptors, vestibulo-ocular reflex, the eye movement that stabilizes the vision during the head movement. It produces equal and opposite eye movement based on an angular acceleration direction by the sensory canals. Works through a three neuron arc, that is vestibular receptor, vestibular nuclei, ocular motor nuclei. So these are the and this is the pathway how it actually the movement of the eye has been explained. So these are the inhibition and excitation or excitation. So how this the movement of the head rotation towards the head, left and the right, and how that ocular muscles occurs. So these are the VOR, vestibulo-ocular reflexes, angular and the linear. Angular from the central canals directs the rotation. From the linear are from ventricle and saccules that directs linear movement and the gravity. So this is again the video, but due to the lack of time and this so in for this anatomy level, then you can see this how the vestibulospinal and the vestibulocoelic reflexes they are dependent and how the balance occurs. Actually, we all know there are three receptors: proprioceptors, or these visual receptors, and the body itself. That actually three of the organs when they come together, the balance maintained. One of the sectors or that disturbance, the vertigo or the dizziness occurs. So this is a brief presentation. So thank you to all.
So after this wonderful presentation by Dr. Gurchan, we would like to felicitate Dr. Gurchan, and I request our chairpersons to please be on the dais to felicitate our honored speaker, Dr. Gurchan. May we have a round of applause? The clap must continue. The chairpersons, please be over the stage only. I request Dr. Ravneet to felicitate Dr. Poonam. So after this wonderful session by Dr. Gurchan, it is time for our guest speaker to be on the dais. That is Dr. Shani Bhatia, who has come all the way from Solan. She is professor over there at the Solan Medical College, and she happens to be my postgraduate student too at Patiala. And we welcome Dr. Bhushan Patil and Dr. Prashant, who have come all the way from Gurgaon. A very warm welcome to you, sir. For this session, we have the chairpersons with us. Please welcome Dr. Dilip, sir. Dr. Dilip on the dais. And Dr. Tanu would be joining Dr. Dilip. And before Dr. Shani starts with her deliberations, I would request Dr. Dilip to please read her biodata.
Dr. Shani Bhatia completed her MBBS from Government Medical College, Amritsar, and post-graduation in ENT in 2002 from GMT Patiala. Currently, she is Professor ENT and managing neurological clinics in So, completed an international online vestibular diploma in 2021, has 16 publications in national and international journals as well, and written various books also. attending and presenting many national and international conferences, lifetime member of AOI, American Association of Otolaryngologists, and European Society of India, and also international. So I request, I welcome Dr. Shani Bhatia for this presentation, and we request to start with the class.
Thank you, sir. Respected chairpersons, my colleagues, a very good morning to all of you. Before I start with my presentation, I would like to thank my teacher, Dr. Gill, as well as all of his team. It's an honor to come and speak and share my knowledge with all of you. Thank you so much, sir. So, before I start with this lecture, I will just give a slight background that neurology, of course, being a new subject, we were not much taught or we were not aware of this subject till our post-graduation. So it was much later when this department was handed over to me, I had to look into these kind of patients. And frankly speaking, during that time, there were only two diagnoses which I knew, and that was BPPD and Renal disease. And most of my patients, I used to try to fit those patients into those diagnoses. And obviously, they used to keep on coming back to us again and again. Because it was much later when I attended some conference and workshops where they said that with the advent of neurology, it is extremely difficult. It is extremely, it's a crime if you are not able to diagnose where the lesion is, you know. Maybe we have the treatment, maybe we don't have the treatment, but the diagnosis is mandatory. So then obviously, getting into this field now, little bit knowledge I have gained, which I'm going to share with you. Much way to go, still much to learn. So it happened that during the heavy OPDs, it becomes very difficult to see a vertigo patient because with that detailed history, if we are not taking the detailed history, we are not able to reach the diagnosis. And it was around 3 or 4 years back when my postgraduates used to tell me that please make some performa so that we can take up the history because otherwise we miss up the points. So it was for their benefit that we came with this multidisciplinary approach, and my approach today, my topic is a multidisciplinary approach to the vertigo patient. So we know that vertigo and dizziness, that is a symptom, it is not a disease, and the etiology is multifactorial with various clinical overlaps among different vertigo syndromes due to multiple levels of involvement in the vestibular pathway. The multidisciplinary approach for vertigo entails active participation of a team which comprises of physicians, neurologists, otolaryngologists, audiovestibular specialists, psychiatrists, physiotherapists, orthopedicians, and neurosurgeons based on the clinical features. So, a careful history remains the cornerstone of diagnosis. Once the correct diagnosis is made, specific and effective treatments are available for both peripheral, central, and psychogenic form of dizziness. History taking can be challenging in most patients as certain symptoms are difficult to identify with just one or two questions. That is like patient. And in our daily clinical practice, we do come across patients who can have varied presentations. A patient of seizure will also come to the vertigo clinic. A patient of having blurring of vision will come to the vertigo clinic. So it becomes very difficult to point out whether that patient belongs to the otolaryngologist or neurosurgeon or whatever the field is. So then we came with this acronym, and that was confounded. Confounded, the C stands for the chief complaint. O is if there are any other medical problems which are present in the patient. N is if there are neurological symptoms which are present. What is the frequency of the attacks? If there are any associated pathological symptoms present. If there are unusual non-vertiginous symptoms which the patient is presenting with. If there is nystagmus during that time or it's not there, duration and development of these symptoms, what are the excitatory triggers and what various drugs the patient is taking. So according to the Barney Society, now the symptoms are divided into 4 categories. That is the vertigo, dizziness, vestibular-visual symptoms and postural symptoms. All the patients who are coming to us in our OPD, we have to divide them into these 4 categories, and that is vertigo, dizziness, vestibular-visual symptoms and postural symptoms. Vertigo, we know, can be objective or it can be subjective. That is, it can be internal vertigo, that is the patient is saying my head is moving, or it can be external where he says the room is moving, the surroundings are moving. So dizziness has been defined by many people. First and foremost, by New Hostel says dizziness has been described as one of the foremost common medical conditions affecting 15 to 35% of the overall population at some points in their lives. Dizziness is often classified into 4 categories: vertigo, disequilibrium, that is without vertigo, pre-syncope, that is near faint, or it can be psychophysiological dizziness, which is commonly related to anxiety and panic. But now, the Barney Society has not defined dizziness, but it does say what is not dizziness. And what is not dizziness, that is particularly pre-syncope is not dizziness. That is the near fainting. Disordered thinking, if the patient is coming up, that is the mental confusion, that again is not dizziness. Detachment from reality, that is depersonalization or derealization, motor weakness and malaise. All these do not fall into dizziness. So lightheadedness is often described as floating dizziness or wooziness. The patient says, I'm floating in there, hawa mein ud raha hu. Elderly who have visual dysfunction, that is the macular degeneration, balance difficulty, as the sir mentioned, the 3 systems which manage the balance. If the proprioception, which gets affected with age, if there is some pathology over there, and along with that, if the patient has got some hearing loss and peripheral neuropathy, patients are thus effectively cut off from the receiving accurate information about the orientation of the environment, which often leads to dizziness. Now, vertigo and dizziness, it can be spontaneous or it can be triggered. The patient says, मैं जी बिस्तर पे लेटा हुआ था, मैंने करवट बदली तो चक्कर आ गया. Or he can say, I was walking on the road and suddenly there was vertigo. So it can be spontaneous, it can be triggered with some kind of various triggers which we will be taking up in detail. So triggers are always having temporal relationship and they are repetitive and reproducible. That is, till the time the trigger is there, the vertigo is going to persist. 1. And whenever we are going to give the trigger to the patient, that means it is repetitive. We can reproduce it, reproduce the same vertigo if we give that kind of trigger. So the response placed the dizziness into one of the 3 clinical scenarios. That is the episodic trigger. It can be spontaneous, episodic, or it can be continuous. By episodic trigger, whenever you give the trigger, the episode of vertigo occurs. There can be spontaneous episodic, that is spontaneously, off and on the vertigo is occurring, but in episodes. Or it can be continuous. The patient is saying 24 घंटे 2 दिन से या लगातार मुझे चक्कर आए जा रहे हैं. Now, vestibular-visual symptoms, like the first Barney Society has divided into vertigo, vestibular-visual symptoms. So this is the vestibular-visual symptom, that is the external vertigo. Then the movement-induced blur, when you are moving in the car, in the bus, or any kind of movement, the patient says there is blurring of the vision when I look out of the window. There can be oscillopsia, that is the patient is not able to read anything while when he or she is walking. They say चीजें हिलती हैं, I am not able to read properly. Or visual lag and visual tilt, that is there is a tilt. मेरे को लगता है थोड़ा कमरे की वो दीवार जो है वो हिल थोड़ी सी tilt हुई लगती है. So these are the various symptoms which fall into this category. Then comes the other medical problems. As we know, it has got a multifactorial etiology. Not one specialist can detect and not one specialist can treat the patient of vertigo. So obviously when the patient is coming to you, you have to rule out, as an ENT surgeon, we have to rule out if there are other medical problems. That is hypoglycemia, that can again give rise to dizziness, anemia, hypothyroidism, phobic vertigo, or it can be produced by the renal and hepatic clearance if there is that is reduced. That again that can give rise to disease spells, reduced vascular reflexes which promote increased orthostatic hypotension. Typically the patient says, जब मैं खड़ा होता हूँ तो मुझे चक्कर आता है थोड़ी देर के लिए. Various serious pathologies and ophthalmoplegia. If there is ophthalmoplegia, if there is a palsy of some kind of eye muscle, again that will give rise to this symptom. The medical history conclusion, non-vertigo dizziness can be because of anxiety, panic attacks or depression. Ophthalmoplegia, chronic progressive external ophthalmoplegia or vertical heterophilia. They again give rise to this symptom. Very important for each one of us because that is the something which we fear in case of vertigo. If we are missing out something, something pathological which is an emergency to treat. So any kind of neurological symptom, watch for the deadly Ds, that is the dysarthria, diplopia, dysphagia, dysphonia, dysmetria, dysesthesia. Any history of these deadly Ds, send the patient immediately to the neurologist. If there is any history of loss of consciousness, remember one thing, 99% of the vestibular disorders other than the vestibular epilepsy do not have loss of consciousness. So any history of loss of consciousness, again straight away for the neurologist. Be aware of sudden, severe or sustained headache that the patient is getting or pain in the posterior part of the neck. Again, then we suspect some kind of central pathology. So diplopia, dysarthria, loss of consciousness can be due to tumor, CVAs, vertebrovascular insufficiency. If there is a history of headache, it can be due to migraine, it can be due to Meniere's disease, it can be due to tumor. Then whatever these attacks are occurring, you have to find out about the frequency of these attacks. How frequent are the attacks? So the number of attacks is usually inversely proportional to the length of the time of each attack. It can be a single attack, it can be the patient can come to you with constant history of dizziness or vertigo, or there can be multiple attacks occurring in one day with in between normal episodes, with the normalcy in the patient. So the frequency of these attacks can vary from seconds to hours to days. So this is a very important point which has to be asked in the history. So what are the various attacks which occur singly, which occur in single? It can be stroke, it can be labyrinthitis, that is the inflammation of the labyrinth. It can be neuritis or vestibular neuritis, that is the eighth nerve, where the eighth nerve gets involved, iatrogenic or GI. While in multiple, we know that the multiple attacks, recurrent Meniere's disease, it can be migraines, it can be PPVD, which is a triggered attack, it can be chronic attacks, superior semicircular canal dehiscence, or it can be vascular insufficiency. Then we are supposed to ask as ENT surgeons if there are any associated pathological symptoms that can be giving loss. We have to ask whether it is unilateral or bilateral, whether it was sudden or insidious, or is it progressive in nature. Tinnitus, if it is objective or subjective, unilateral or bilateral, if it is continuous, pulsatile or intermittent. If there is any history of oral fullness, if there is any history of pain or ataxia, ataria, and ET dysfunction. Concomitant symptoms of oral fullness are seen in Meniere's disease, acoustic neuroma, facial weakness is seen in some kind of tumor like acoustic neuroma, etc. Ataxia is seen in migraine, ET tube dysfunction, and herpes osteoporticus. Hearing loss in tinnitus is seen in Meniere's disease, acoustic neuroma, cholestic tumor, labyrinthitis, perilymphatic fistula, stroke, and involving eye cup. So these are the unusual non-vertiginous symptoms. again the Barney Society has divided the patients into this category. That is the unsteadiness if the patient is coming to you. जब मैं चलता हूँ मेरे को बैलेंस नहीं लगता है, और they can be directional pulsion. जब मैं चलता हूँ तो मुझे धक्के लगते हैं. The धक्के can be one-sided, it can be retro, it can be multi-directional. It can be balance related near fall. He doesn't fall, but he feels that I'm going to fall and he holds on to something. And then there is balance related fall, that is गिर जाना. So any person with a fall of one fall per year, spontaneous fall, needs proper evaluation as well as the treatment. Then the next thing which we are supposed to see if the patient of vertigo or dizziness comes to us is nystagmus. What is this nystagmus? As we know, it is a rhythmical movement of the eye, and with this nystagmus we are supposed to differentiate between the peripheral and central pathology. And what is it? In normally the peripheral pathologies there is a horizontal and torsional component, while in central it is purely vertical and can be occasionally horizontal or torsional. We all know that peripheral nystagmus gets inhibited by fixation. It doesn't change with gaze direction. While in case of central pathology, it is not inhibited by fixation, it is direction changing with gaze. So nystagmus, if the patient is having spontaneous nystagmus or the patient is coming to you with nystagmus, this is the main thing by which we are going to differentiate between peripheral and central pathology. Then comes the duration of these attacks. When the patient comes to you with these various complaints, we are supposed to know how much is the duration. So is it fleeting? Dizziness lasting less than a second? Probably is the result of disequilibrium due to an imbalance in peripheral vestibular inputs. Short lasting, vertigo lasting between few seconds and a few minutes is usually due to peripheral vestibular dysfunction. Intermediate vertigo lasting between 20 minutes and several hours can result as due to central pathology or peripheral vestibular disorders. Long-lasting and isolated attack of vertigo lasting longer than 2 to 3 hours and usually a day or days usually result from unilateral complete permanent injury to the peripheral vestibular pathway, and if it is continuous, that is relatively uncommon but serious problem. It can be due to central dysfunction. So these are the various, if it is short, it is from seconds to minutes. The various causes are BPVD, perilymphatic fistula, semicircular canal dehiscence, vascular insufficiency, Chiari malformation, or it can be iatrogenic. Intermediate, 20 minutes to 2 hours, it can be due to Meniere's disease, it can be due to migraine, metabolic, or due to syphilis. Of course, nowadays not very common, syphilis is not very common. It can be due to panic attacks or TIA. While the long lastings, which usually last more than 24 hours, is the labyrinthitis or vestibular neuritis, temporal bone trauma, stroke, multiple sclerosis, and autoimmune disease. How does this disease or how does this symptom develop? So how does the disease progress? Vestibular neuritis typically is very disturbing in the early stage with gradual improvement over days, whereas Meniere's disease is characterized by sudden attacks with periods of little to no vertigo in between. All other forms of vertigo typically have a stable course of intensity or are characterized by progressive or fluctuating severity of symptoms. One of the rare vestibular disorders that will worsen over time is triple PD, which is a psychogenic type of dizziness. Very debilitating, and the patient keeps on coming to you again and again until and unless we treat that disease. So what are the precipitating factors? It can be positional, as we know, head motion, sound induced, valsalva, or orthostatic. Most of us see the patients very often with the orthostatic hypertension. That जब मैं खड़ा होता हूँ, बैठ के उठता हूँ, सो के उठता हूँ, तो मुझे चक्कर आता है थोड़ी देर के लिए. So what are the excitatory triggers? It can be altered head position, which is seen in BPDB. जब मैं करवट बदलता हूँ बिस्तर पर, it can be rapid ascent, which is due to orthostatic hypertension. Neck extension is vertebrobasilar insufficiency. Stress, mostly due to psychiatric. or migraine headaches. Salt type again leading to Graves' disease. Headache is migrainous. Ear pressure is seen in perilymphatic fistula and semicircular canal dehiscence. Loudness is due to chronic ear surgery or semicircular canal dehiscence. जब मैं चल रहा होता हूँ पीछे से अगर कोई हॉर्न तेज बजाए तो मैं या तो गिर जाता हूँ या मैं बैठ जाता हूँ. So this is a typical symptom of your semicircular canal dehiscence. What are the other triggers? It can be dehydration, it can be the various drugs which the patient is taking, it can be environmental, exercise, hyperventilation, it can be voyages, especially the people who are taking vacational voyages stand up with this kind of disease spells when once they are back, or it can be idiosyncratic. So what are the various drugs which produce a non-vertiginous sense of dizziness described as lightheadedness? Normally anti-anxiety drugs like Lovalium, antihistaminics like the Benadryl, etc., diuretics like Lasix, antihypertensives, calcium channel blockers, anti-inflammatory, antidepressants, antibiotics, especially are gentamicin, streptomycin, amikacin, and chemotherapeutics like the cisplatin and carboplatin. So when you are taking up the history, the basic history, there are, what are you supposed to ask? The attacks, whether they are acute, whether they are episodic, or they are in combination. And then we can take up, there is another approach which is known as so-stoned approach. What is that so-stoned approach? Symptoms, how often they occur, since when they are occurring, what are the various triggers, any neurological sign which is present, which I said, watch for the deadly leads, if how these symptoms they evolved and what was the duration. This is more for the acute one. But what about if the patient is coming and telling you, मुझे तो साल से चक्कर आ रहा है, मैं तो जी खड़ा ही नहीं हो पाता, चक्कर आप क्या पूछ रहे हैं, मैं तो सारा साल 6 महीने से मुझे चक्कर ही चक्कर आ रहे हैं. Then the approach changes. Then the approach is disco hack. What is disco hack? It is, you are supposed to ask in history if the patient's symptoms they get triggered if there is any kind of imbalance in the supermarkets or in the places where there are a lot of people like marriages, melas, etc. If there is any decline in cognitive function, if there is oscillopsia, headache, autonomic function, and if the patient has a lot of malaise or tiredness. So that is the full form of disco hack. The patient says no, there is no positive history of these. Then what are you supposed to do? You are supposed to screen the patient for any kind of functional, psychological or psychiatric comorbidity, triple PD, anxiety, and also take up the past medical history of the patient. And then becomes the comprehensive diagnosis. So this is how you reach to the diagnosis. As I mentioned in my during the start, now with the advent of all the history as well as investigations, remember one thing, no patient should go without diagnosis. Maybe we are able to treat, maybe we are not able to treat, but you should not send any patient writing down vertigo under evaluation. No, you are supposed to make the diagnosis by reaching whether it is peripheral or central. So this was one approach which was initially taken up by the earlier otolaryngologists, and that was the titrate. The full form was titrate, and there was another acronym, and that was the timing of the attacks. Again, they were dividing into acute and chronic, and what were the various triggers. The same thing which we have taken up in detail, but this was the acronym initially which was used for titrate, but still it had its own loopholes. We couldn't reach to the proper diagnosis, so that's why this was abolished. So-stone has been taken over, but we have made our own acronym, and that is confounded. And we are going a step further by just not having the history taking, but also an acronym for the investigations as well as for the treatment part. So, thank you for the patient hearing.
Thank you, ma'am, for such an insightful session. Now, I would like to call our chairperson, Dr. Dilip and Dr. Tanu on the dais for the felicitation of our speaker. Now, I would request Dr. Deeksha ma'am to kindly felicitate our chairpersons. We will be continuing with the inauguration ceremony in 5 minutes. We'll wait for our education.
So, may we have your attention, please? We start with the inauguration.
स्वागतम, सुस्वागतम, शुभ स्वागतम। आज के सब मेहमानों का हम हार्दिक स्वागत करते हैं, तहे दिल से अभिनंदन करते हैं। We welcome you all the most distinguished guests at this conference on vertigo happening on 11th of April at Adesh Medical College, Shahwat. A pleasant morning and a very warm welcome. It is my proud privilege to have you all at this conference on vertigo, a symptom that, though often described simply as giddiness, represents one of the most intricate intersections of pathology, physiology, and neurology. Vertigo is not merely a complaint, it is a clinical puzzle. From peripheral causes such as benign paroxysmal positional vertigo and menias to central etiologies involving the brainstem and cerebellum, it challenges our diagnostic precision and clinical judgment. Keeping this in mind, we have engaged two of the great clinicians of the regions to showcase their skills and live demonstrations. Today's conference aims to provide a comprehensive platform to revisit the fundamentals, discuss recent advances, and share clinical experiences in management of vertigo.
As a matter of fact, Adesh Medical College and Hospital was established in the year 2017, is located near Ambala Camp in district Kurukshetra, Haryana, affiliated with Pandit B.D. Sharma University of Health Sciences, Rohtak, and recognized by the National Medical Council. The institution offers undergraduate and postgraduate medical programs, including MBBS and various MD/MS courses. The college admits 250 students annually into its MBBS program and approximately 75 postgraduate students in various specialties. Besides this, the college also offers courses on nursing, physiotherapy, and pharmacy. So let us not forget that we are here at a very auspicious place of Kurukshetra, which has its roots to the epic Mahabharata. Thus, the place is not only famous for its grandeur, but the royal hospitality too. So, dear colleagues, we have not left any stone unturned to offer you with the best of cuisines and delicacies at the banquet. With these few words, I once again extend a warm welcome to all our esteemed guests, faculty, delegates, and students.
Now, I would like to take this opportunity to invite on the dais our very esteemed director of Adesh Group, Mr. Gurfateh Singh sir, and I would request our HOD sir, Dr. GPS Gill sir, to kindly accompany the sir to the dais. Now, I request Dr. GPS Gill sir to felicitate our director sir. Now, it is our proud privilege to call on the dais Director Admin Dr. Gundas sir, and I would request Dr. Gurchand Singh sir to kindly accompany the sir to the dais. It gives us immense pleasure to invite on the dais Principal Dr. N.S. Lamba sir, and I would request Dr. Chetna ma'am to kindly accompany sir to the dais. Dr. Ramneet sir to kindly accompany the sir ma'am to the dais. Now I would request Dr. Ramneet ma'am to felicitate Principal sir. It is our great honor to invite on the dais Registrar Haryana Medical Council Dr. Mandeep Sachdeva sir, and I would request Dr. Deeksha ma'am to kindly accompany the sir to the dais. Now I request Deeksha ma'am to kindly felicitate sir. With great respect, I invite on the dais our Deputy MS Dr. Naresh Jyoti sir, and I request Dr. Chetna ma'am to kindly accompany the sir to the dais. Now I request Dr. Chetna ma'am to kindly felicitate sir. Now I would like to invite on the dais our most respected Secretary, AOI Haryana Branch, Dr. Bhushan Patil sir, and I would request Dr. Siddharth sir to kindly accompany the sir to the dais. Now I would request Siddharth sir to kindly felicitate them. Brahma, Deep Jyoti Janardhan, Deepo Hattu Me Pa, Sandhya Deepa Namostate. Now, according to Hindu mythology, light is considered as a symbol of auspiciousness, prosperity, and abundance. It signifies the dispelling of darkness through the light of knowledge, wisdom, and learning. Thus, I request our director, sir, and all the dignitaries sitting on the dais for the lamp lighting ceremony, and with that, we can mark the auspicious beginning of the conference.
Thank you, sir. May the blessings of Ma Saraswati guide us towards intellectual growth and academic excellence. Let this conference be a beacon of learning, collaboration, and progress. With these few words, I take this opportunity to call on the dais the organizing chairman of this conference, Dr. G.B.S. Gill, sir, for his inaugural speech.
Honorable Director, Mr. Gupta Singh sir, Director Admin, Gupta sir, Honorable Chairman, Principal sir, Dr. N.S. Lapa, the Registrar of Haryana Medical Council, Dr. Navdeep Sachdeva, the DMS sir, Dr. Naresh Jyoti, and my very dear, because he comes from my own alma mater, Dr. Bhushan Patil, who is the Honorary Secretary of AOI, Haryana branch. AOI stands from Association of Otolaryngologists of India, so Haryana branch. So, dear faculty members, HODs, and all my dear friends and colleagues, a very warm welcome and a very pleasant morning to all of you. As I was coming on the dais, I was thinking of this sacred land of Kurukshetra, which has its roots to the epic Mahabharata, and which says that, which has a very timeless saying, which says that Karam Kar Phal Ki Ichha Na Kar, or the work should always be process oriented and not result oriented. And this is exactly what I tell to my postgraduate students, that you must work with your utmost sincerity and hard work, and you are bound to get the wonderful results. So again, the timeless saying, Karam Kar Phal Ki Ichha Na Kar, or the work should always be process oriented and not result oriented. When this idea of organizing this conference came to my mind, myself and my colleague, Dr. Gurjant, we approached Dr. Vartas Singh sir, and his enthusiasm, his encouragement made a lot of boost to us, and he promised us with every kind of logistics which would be required during the conference, and we are very grateful to you, sir. When we approached Mr. Gupta Singh sir, he not only supported me for every kind of logistics, but besides he also promised me with a cup of coffee there in Canada after the successful completion of this conference. I am always grateful to our principal, Dr. N.S. Lamba, because whenever I approached him for any kind of tedious works, he always welcomed me with open arms. My heartfelt gratitude to Dr. Mandeep Sachdeva sir for giving us the credit hours and joining us at such a short notice. I am always grateful to DNS sir, Dr. Naresh Jyoti, for his very calm and cool demeanor. I wish that prophet is coming me also. And as I said, Dr. Bhushan Patel, who comes from my own alma mater, that is Mahatma Gandhi Institute of Medical Sciences, Wardha, and we welcome Dr. Bhushan. And he is the honorary secretary of AOI of Arena branch. See, whenever you think of a conference, the next thought that comes to your mind is the number of registrations. And with the support of you all colleagues, we have reached the 3 digits. So we are very grateful to all of you for making this conference a success. At the end, I would like to say that conferences are usually meant to eat, greet, and then to disperse. But then this conference is with a difference that not only have we arranged the best of the clinicians of the region for their deliberations, but also the best of the culinaries of this region. And I hope you enjoy both. Just one thing which more I want to add is that for any teacher, it is very, very important that, or very satisfying when his postgraduates do well in life. So today's 2 star speakers were my postgraduate students here in Patiala, Dr. Shani and Dr. Sandeep. Could you please stand or wave your hands? So they are doing very well in the field of VERTIGO. And it is such a satisfying moment for the teacher whose postgraduate students then excel in life. So with these few words, I once again am grateful and thankful to all of you, and I wish that you have a very enriching and a very enjoyable day. Regards and lots of thanks. Thank you.
With great honor, I invite to the dais our DMS Sir Dr. Naresh Jyoti Sir for his kind words.
Respected Director, Adesh Group, Gurupati Singhal ji, Dr. Arman, Dr. Gurdas Bhai ji, Principal Dr. N.S. Lamba ji, Haryana Medical Council Registrar Dr. Mandeep Sachdeva ji, and Sir Dr. Bhushan, sorry for forgetting. And many congratulations to Dr. J.P.S. Gill and Dr. Gurchan Singh Gill and whole team for organizing a wonderful conference. So when I was looking at the topic, the VERTIGO, the dilemma. So I tell you my own experience. In my family member, 79-year-old, with a history of imbalance, sometimes dizziness, sometimes episode of VERTIGO, but diagnosis was missed totally. And he was shown in very prestigious hospital in the Delhi, and in every, like Vedanta Apollo, and every specialist say that everything is okay, and diagnosis was missed. And then they called me. I just consulted with Dr. Vaneet, is sitting over here. He guided me in Delhi that he referred to his friend geriatricians. We consulted with them, but after intensive consulting, so there was ENT department, and we reached the diagnosis of venous disease. Electrocochleography was done, it was positive. And that was VERTIGO, so much dilemma that in VERTIGO the total quality of life is lost, and that is But diagnosis was based on each and every investigation in same day, but our every investigation that there were no structural changes. Sometimes we ascribe it to the age changes, cervical and postal hypotension. That was not the case. And diagnosis was reached, it was good, and expected outcome, what we wanted, it started coming. And there was also dose of the beta histone to be given. I personally, met this in Max, Apollo, Vedanta, different Max, ALK, Max, K. Lot of confusion about the dose of beta histone. So lot of dilemma in this. I'm talking about my personal experience. When I see the topic, it was wonderful topic. It was very close to my heart. So congratulations to all the entry department for putting up this conference. Thank you so much.
Now I invite on the dais the Honorable Secretary of AOI Haryana Branch, Dr. Bhushan Patil, to say a few words.
Thank you. The respected dignitaries sitting on the dais and the organizing team led by Dr. GPS Gill sir. This is my second year consecutively coming to Adesh Medical College for this symposium. Last year I remember it was on thyroid disorders, and this year on VERTIGO. Yes, as the doctor said, VERTIGO, it's always a challenge. And it's so nice that the hall is full of students who are eager to learn the intricacies of diagnosing VERTIGO so that in their future life they help their patient achieve what they want to by giving them best treatment possible for VERTIGO. These kind of small symposiums are always helpful rather than big workshops. So when Sayu mentioned that you've already crossed 100 delegates for this workshop, it's really nice to see people interested in learning. So I wish you all the best. It's very nice to see, and hopefully next year you'll again come to attend this day. Thank you so much.
With great respect, I call on dais our Principal Sir, Dr. N.S. Lamba, for his words of encouragement.
Good morning, everybody, the dignitaries of the dais, the actuaries here, the faculty, the postgraduate students. It is always good to see a hall full. You've heard about VERTIGO, and it's a quantum of in medicine which is very difficult at times to diagnose and crosses all specialties. Very often a question that comes to me when a CME like this is planned that from various departments that why should PGs from some specialty attend something which is not related to them. So medicine cannot be practiced in silos, that we all know, and the topic is such that it converges across specialties, whether it is medicine, whether it is neurology, whether it is psychiatry, medicine, and of course ENT. So I think postgraduate students, and that is why the NMC also wants us to make sure that the students attend CMEs across specialties. And I think that is what it makes you a good doctor, it makes you a good physician, good clinician, if you know something about the other people, other specialties other than your own. The other thing is that educational institutions like ours is known or should be known for the number of CMEs that we conduct, because this is a process of continuous learning. It all depends on what knowledge we impart to our students. So I would request all the HODs to please plan a CME. We should be having one CME every 2 to 3 months in this hospital. It's an educational institution. The more the number of CMEs, the more the value that we give to our students. So that is my request to all the HODs. Come forward, put up your plan. We are always there to help you plan a CME. And for the postgraduate students, sit and listen. I'm sure you will gather something from this. And I congratulate the department for a wonderful topic. And I would request others also to select topics which matter to everybody, which are cross topics, topics which cover various other specialities. And I thank the HOD for the wonderful topic, and also thank the speakers who have come from outside to give us that expert talk. We are looking forward to hearing from them. Thank you very much, and have a great day.
Now I take this opportunity to call on the dais the Registrar of Haryana Medical Council, Dr. Mandeep Sachdeva sir, to share a few words.
Respected dignitaries on the stage, Director Admin Gopal Singh, Principal Sir, Dr. Bhushan, Dr. Naresh, and organizing team, Dr. GPS Skills and Gulcharan Singh, and congratulations to all of you. Some of my teachers are also sitting, Dr. Sushil, my classmates, Dr. Devani. I am very happy to always come to here. And today's very, very important topic, vertigo. Actually, वर्टिगो जब प्रॉब्लम किसी को आती है, बंदा बैलेंस नहीं मेंटेन कर पाता, तो बंदा कंफ्यूज हो जाता है, मैं ईएनटी वाले के पास जाऊं या न्यूरोलॉजिस्ट के पास जाऊं. तो आई विल डॉक्टर जीपीएस गिल टू गिव सच इंपॉर्टेंट सीएमई. कांग्रेचुलेशन टू ऑल. थैंक यू.
It gives me immense pleasure to invite on the dais Dr. Guntas Singh sir to enlighten us with his thoughts.
Good morning all. Respected Director of this group, Principal Sir, DMS Sir, and Dr. Bhushan, Secretary AOI, and Registrar HMC. I would like to thank all of you for taking time out of your busy schedule and be with us. Thank you all. And our respected HODs and faculty who have gathered here to gain some knowledge on VERTIGO. As my earlier speakers have elaborated on the fact that it is just a common topic which everybody should be knowledgeable about. I see Dr. Naresh Jyoti helping a lot of patients. He is from a non-clinical background, but he has very good clinical knowledge. Over the year, he has learned knowledge, gained knowledge from all of us, discussing with different faculty members, different departments. So that is the importance of knowing, learning topics which might not be in your domain, but then if you have knowledge, then you can guide the patient, guide your relative, guide your friend in the right direction. You might not be able to treat it, but at least you know where to send in, how to get things done. So that is the most important, the guidance which we can give to our patients, to our relatives. So I congratulate Dr. GPS Gill, Dr. Gurchan, and the entire ENT team who have selected this topic and made this into a very good symposium and a CME where everybody can gain knowledge and share their thoughts with the external faculty who have taken time out to be with us. So congratulations, sir, on this wonderful platform you've given to everybody. Also, I would like to mention here that last year we have started our VERTIGO lab in the Department of ENT. So I'm sure somewhere it has clicked his mind as to a CMU on VERTIGO. So this is second year running by the ENT department of conducting such CMEs. So I think they need a big round of applause for making sure that they are covering, they covered thyroid last year, this is VERTIGO. And I'm sure their mind is already running for next year. So what do they want to do next year? So again, I I think Dr. Lamba is always there to guide you all and make sure everything is in place. And wonderful arrangements. Apart from good knowledge, they've elaborated on good, cuisines also, which is very much, I think, lot many people will be interested in. So, gain knowledge, make friends, and share your thoughts and have a good lunch and a tea today. Thank you.
Now I call on the dais Mr. Gurfather Singh sir to share his impactful insights.
Dr. Lamba, Dr. Guldas, Dr. Mandeep, Dr. Bhushan, Dr. Jyoti. First of all, welcome Dr. Mandeep and Dr. Bhushan to Adesh, welcome sir. All the attorneys, faculties and everyone, all the participants also. So first of all, it's my privilege to join you today sir, and I congratulate Dr. GPS, Bill and Dr. Bhujan for organizing this symposium, and it's a very good platform. So what we think that if we go to any other field, in non-medical field, in household also, when we discuss, when we get together, we discuss with each other, there are always new ways for the things to do. And same is this symposium. When we are getting together over here, you are talking to each other, you are sharing your ideas, sharing your knowledge, and it's always beneficial for all of us. And further, this is also beneficial to the common man. So some of you might be a new residents over here who are learning stage. So they will learn the new methods and new things will be discussed over here. So they can be helpful for the common man, which are suffering from VERTIGO. And I really appreciate this effort, and I congratulate Dr. Guldas and Dr. Lamba sir for motivating the staff and pushing them for doing all these CMEs and faculty development programs. With this, I will once again congratulate you sir and your team, all the department of ENT for organizing this, and wish you all a good night. Thank you.
And now it is the time to call on the dais the organizing secretary of the conference, Dr. Gurchan Singh sir, to propose the vote of thanks.
So today we are not actually our honorable chairman sir was busy with the inauguration, but with respected chairman sirs, honorable director Adesh Group, ST, the admin director Guldas sir, honorable principal sir, deputy MS sir, distinguished faculty members, and HODs, respected speakers from all over the North area, and dear colleagues, all delegates. It is my proud privilege to be the proposed vote of thanks on this enlightening occasion of the VERTIGO Symposium. At the outset, I extend my heartfelt gratitude to the honorable respected chairman sir for his constant guidance, encouragement and visionary leadership, which continues to inspire us to strive for academic excellence. So I extend my sincere thanks to our esteemed the director Adesh Group, Gurfateh sir, for his invaluable support and for nurturing an environment that promotes continuous learning. I express my sincere thanks to our esteemed admin director Guldas sir for his unwavering support and for the fostering an environment that promotes learning and excellence growth. I am equally grateful to our principal Lamba sir, Deputy MS sir for the administrative support and seamless coordination that made this event possible. A special note of appreciation to all the distinguished speakers, to AY Secretary sir, to the Haryana Dr. Sachdeva sir, and their advanced the field of VERTIGO to in the making out the time to come over here. I hope these speakers' insights will truly enrich our understanding and will greatly benefit our clinical practice, and the most important is patient outcome. So I would also like to thank all the faculty members and organizing team whose hard work, dedication and meticulous planning ensured the smooth execution of this symposium. My sincere thanks to all the delegates and the participants for your active involvement, which will make this event interactive and more meaningful. So lastly, I extend my gratitude to everyone who worked behind the scenes and contributed in any way to make this symposium a great success. Thank you all. Please.
Thank you, sir. May we all rise for national anthem, after which we will all proceed for the high tea.
It is bringing more disrepute to vertigo than as a treatment because we are using it as a blanket treatment. Because we are not sure of the diagnosis. And then a great No, sir. I'm talking of general population, but how 8 milligram BD along with phenarazine, which is antihistamine, beta-histamine is histamine analog, we are putting both in the same prescription.
थोड़ा कट कर दो वाले
मैं इसको दूर कर देता हूँ Yes, sir. Now, actually it was less audible when So, if time permits, with all the evidence, I will take 5 minutes to show what should be the dose, if that time. But first coming to my topic, whether you practice neurotology or not, you may become a great thyroid surgeon or a rhinoplasty surgeon in your career, but you will definitely encounter one or the other time in your life and you will definitely encounter vertigo patient and that too BPP. In your family or in your surroundings, you will definitely encounter BPP. So, my BPPV I will dwell into the theory as much as you will want. Let us start. How will you approach a patient while sitting in your clinic? सवाल पूछने से पहले भी one must understand कि क्यों पूछना, क्या पूछना. कान के अंदर बैलेंस के लिए I'll be talking in terms which should be very. See, it is a very. To be a good neurologist, you must behave like an ENT specialist, like a neurologist, like Madam said, like a physiotherapist, and like a psychiatrist. You must know bits of everything. Starting with basic anatomy, see the angular acceleration of head can move in yaw axis like this, in this axis. It can move in pitch axis like this, or it can move in roll axis like this. Head can, naso-occipital axis, roll axis, in roll plane, head can move and this way, and then yaw axis. This is angular acceleration of it. Then there can be linear acceleration of it, like sideways, front to and fro, or up and down, like going in a lift. That is linear acceleration. So head can move in 3 axes, yaw, pitch, and roll, or linear acceleration to and fro, sideways, and up and down. And vertigo can present in all 3 axes. So if a patient comes to you and says, "Doctor, I am feeling swaying this way and that way," is your patient? So, 3rd year postgraduate student, please raise your hand. What are the organs in inner ear to judge the angular acceleration? No, utricular and saccular are not the organs to judge the angular acceleration. They are the organs to judge the linear acceleration. And 3 pairs of semicircular canals are they judge the angular acceleration. The horizontal pair of semicircular canals, they judge the angular acceleration of head in yaw axis. See, I won't go into physiology, that will take around 15 to 20 minutes, but bony canal, like a ball penny, refill, and then in that case, and then there is blue ink in that, and olive perilip, you can imagine that. And when you move your head suddenly to one side, the bones move, but the water tends to stay there and there. That is physiology, we will not go into it. So, The two semicircular canals, see, if you move water like this, it will hit the cupula here, but it will move away from the cupula here. So there will be equal and opposite types of action. Again, physiology, I won't go into details of it, but what I want to say is there are three pairs of semicircular canals which judge the three types of angular acceleration. The horizontal pair judges the movement in the pitch axis, the left anterior and right posterior, and the right anterior and left posterior. They being in the same plane. So they judge the movement in the pitch and in the roll axis. Understood? कोई प्रॉब्लम नहीं। मैं कहीं से कोई चीज उठाऊंगा, भानुमति ने गुणवा जोड़ा, कहीं से कुछ उठाया, कहीं से कुछ कैसे बात करेंगे, पर अपने को पर समझ लेते हैं तो बढ़िया है। इवॉल्व नाम का एक प्राणी हुआ है, उसने कबूतरों के, पिजन्स के सेमी सर्कुलर कैनाल पे बड़ा कुछ कर करके कुछ लॉज डिड्यूस किए। तो उसका इवॉल्व फर्स्ट लॉ स्टेट्स दैट डायरेक्शन ऑफ nystagmus is in the plane of the canal. So horizontal, vertical canals or rotational. So nystagmus, that is a normal movement of the eyes, can occur in horizontal plane, vertical plane or rotational plane. Horizontal, vertical, superior and posterior, up or downbeat nystagmus, and rotational roll axis में अगर होगी तो now it may seem dissociated at present, but the things will gel up. So this till now सिर्फ एक चीज समझने वाला, what we have understood is there are three pairs of semicircular canals to judge the angular acceleration of the head in three axes. Understood? Your ventricle has macula. Macula? Ventricle and saccule, they have macula. They are meant to judge the linear acceleration. Now, what is macula? Macula is like a pastry, cake, pastry. There is a base. Base is made up of hair cells, which have type 1, type 2 cells, which have hairs projecting outside. So these hairs are embedded in a matrix which is cream of the pastry, and in the cream are embedded choco chips, which are akin to calcium carbonate crystals. So there is a pastry lying horizontally, and then in the ventricle, and there is a pastry lying here vertically in the saccule. So this pastry is our mainstay of BPP. In this pastry, we have base of hair cells gelled together, whose hairs are projecting outside in a gelatinous matrix known as cupula or cream, in which are embedded ortholiths or calcium carbonate crystals. Understood? Done? In old age, after menopause, sex hormones decrease, calcium binding capacity of the body decreases, bones become brittle. Why not calcium carbonate crystals? Their tendency to get lost in that, there decreases, and they have a tendency to get dislodged out of that cream. The choco chips, they get dislodged out of cream. Simple. Another example. So that means old age, as the age increases, the incidence of BPPV increases. One cause of BPPV. Second, you got your dental treatment done and the person was doing that drilling or even mastered surgery, and those vibrations, they dislodge the ortholiths out of that cream. That is another cause. You suffered from an accident, even a minor accident, fall from a scooty. That is enough to dislodge the oculus. Trauma, another cause of. In your hospital, all the patients who come to your emergency for neurosurgery, everybody knows the vertigo. There are many of them get BPPV. So, trauma, another cause. A vascular injury can get them dislodged. Vitamin D deficiency can get them dislodged. You did a thyroid surgery, patient was lying in this position for days together, and then under the continuous effect of gravity, the particles, they get dislodged and they are floating in the endolymph. So I have just enumerated the various etiological causes of BPPV. Any confusion? So now I will start the slides. Benign, it is not malignant, although it is unless not. Paroxysmal. We will come to it later. So this was this is utricular macula, this is saccular macula, superior semicircular canal, posterior semicircular canal, horizontal semicircular canal. We are not bothered about Cochrane now in BPPV. So I devised my own model when I was studying this vertigo. So I sacrificed my headlight for this. And this is patient is facing B. This is posterior semicircular canal. Green one is superior semicircular canal. This is horizontal semicircular canal. Sir was saying, Dr. Gurjit in the first lecture about the horizontal. Now the patient is facing U, and this is horizontal canal. Its anterior end is not parallel to ground. It is like this. What is the importance? I will come to it later. सारे वीडियोस YouTube भरा पड़ा है, सिखाने वाले बाबा ज्ञान देने वाले बहुत हैं, लेकिन सब यूजलेस है। आपके दिमाग में चलना चाहिए जो पेशेंट की आंख में चल रहा है। अगर आपने वो पढ़ लिया, you will never ever miss something। तो ये 3-dimensional मॉडल एक चीज आपको the 3 एंगल। अब इसमें ये पार्टिकल्स डिसलॉज हो गए, यहां से पार्टिकल्स डिसलॉज हुए, ऑटोलिस पेस्ट्री, हेयर सेल्स, क्रीम, choco chips got dislodged in endolymph. Now they are floating freely in endolymph here, and you are sleeping. Or classical example, thyroid surgery, patient lying for 5 days, when particles got dislodged, what will happen to those particles? They being heavier than the surrounding fluid, they will tend to settle down with gravity. Where will they settle down? Now this is patient lying like this. This is common crus. This is posterior canal. This is anterior canal. So through the common crus, they will tend to enter the common crus, and they will tend to settle here, like the beads. When the patient will get up after 5 days, these beads will move. These otoliths will move. When they will move, they will create a drag of the endolymph. That drag will cause movement of, it will push on the cupula in the semicircular canal. Put movement of cupula on one side. See, vestibular nuclei vestibular system, retina at rest is 0 impulses from both sides. But vestibular system, they are 100 impulses from this side, 100 from this side. They are not at rest. They have continuous firing rate. When head is in center, they are 100. When you move your head to one side, there they go 1000, here go to 100 to 10. So this difference of discharges is interpreted as movement towards one side. Understand? So now what has happened is your movement of autoconia has caused drag on the endolymph, which is causing the ampulla to move. That means either it is increasing or decreasing the impulses. So here 100, here suppose they decrease to 10. This difference of discharges when goes through vestibular nucleus to the cerebral cortex will be interpreted in the light of the past experiences. जन्म से लेके जब से शरीर इधर घुमाता था, इधर 100 से 1000 हो जाते थे, इधर 10 होते थे, ये डिफरेंस ही इंटरप्रेट किया गया। जब ये सेरिब्रल कॉर्टेक्स तक ये डिफरेंस पहुंचा तो उसने कहा सिर इधर घुमा है, और तभी मेरी आंखों ने भी बताया यस विजुअल एनवायरनमेंट घुमा है। तो दैट कोरिलेटेड। अब मैं बीच में कुछ काट रहा हूं। आप गाड़ी में बैठे हो, यहां से सोलन जा रहे हैं मैडम के साथ, और गाड़ी में बैठे अपना मोबाइल चला रहे हैं। अब आपका वेस्टिबुलर सिस्टम बोल रहा है कि चल रहा है, आपकी आंखें बोल रही हैं नहीं चल रहा। तो दिस विजुओ-वेस्टिबुलर मिसमैच मैनिफेस्ट एज मोशन सिकनेस। कभी ड्राइवर को मोशन सिकनेस नहीं होता, हमेशा सवारी को होता है। तो आगे बैठो और ये इमेजिन करो कि मैं गाड़ी चला रही हूँ। उन्होंने कहा नहीं, ड्राइवर को बोलना कुछ नहीं है, नहीं ऐसे चला रहे, लेकिन ये you will never have motion sickness. Now coming back to it. So this, what will happen is right from when child was in womb, सबसे पहला ऑर्गन बनता है वेस्टिबुलर सिस्टम, हार्ट से भी पहले, क्योंकि प्राणी जब जल में रहता था तो वेस्टिबुलर सिस्टम था कान में। जब जल और थल में रहने वाला आया तो डड्डू की मिडल ईयर डेवलप हुआ एम्फीबियंस का। जब प्राणी थल में रहने वाला आया तो सुनाई, तो सेकेंडरी फंक्शन है, मेन फंक्शन तो यही है। चलिए, तो क्या हुआ, इधर जब भी सिर इधर घुमाते थे ड्यू टू एम्पिलोमीटर नॉर्मल फिजियोलॉजी, इधर 100 से 1000 हो गए, 100 to 1000, इधर 100 to 10. This difference of discharges was interpreted, is being interpreted millions of times per day as movement towards left. अब क्या हुआ, by chance, और I have the habit of lying on right side only. मुझे तो राइट पे नींद आती है, रीजन हस्बैंड राइट पे सोता है, तो मैं भी इधर सोती हूँ, इधर मुंह करके, और कॉन्टिन्यूअस इफेक्ट ऑफ ग्रेविटी। इसको बीपी भी बहुत चल, इसको बीपी भी बहुत चल। मुझे तो पिलो लेती हूँ, हाँ सर्वाइकल वाला पिलो लेती हूँ, इसको बीपी भी डेफिनेटली होगी। व्हाई? बिकॉज without pillow your neck is an extension, your this common process facing upwards, particles with gravity will fall into the glass. So it is very common in those people who have the habit of lying without pillow and have the habit of lying on one side. अमेरिकन बोलते हैं कोई पोस्ट मैनुअल रिस्ट्रिक्शन की जरूरत नहीं, 30-40% का रिकरेंस रेट लेके बैठे हैं। यहाँ 2% का रिकरेंस रेट नहीं है। हर मरीज का हर चीज का वीडियो है पिछले 2013 से 13 साल का, और हर पेशेंट का रिकॉर्ड है। देखो, फोन नंबर है, बात करके देखो कि तेरे को दोबारा तो नहीं, ऐसा नहीं। अगर रेस्ट्रिक्शन बताते हैं तो वो अपने ढंग से काम करें, हम अपने से करें। चलिए, तो इधर इस वाली ट्यूब में पार्टिकल आ गए थे। हमने देखा कैसे आए थे, हमने देखा पार्टिकल कैसे पहुंचे थे यहाँ पे। When the patient got up after thyroid surgery 5 days, drag of endolymph, movement of ampulla, इधर 100 ही रहे, इधर 100 से 10 हो गए। Now this difference of discharges will be interpreted in the light of the past experiences that head has moved towards this side, and you will feel like the visual environment has moved from this side, this to this side, illusion of spinning, which is our definition of vertigo. Vertigo is illusion of spinning. So that means, but they cannot continue moving forever. They will come when she got up. They will come and settle within 20-30 seconds. They will settle at a new place. So that means patient will have first attack of, usually has first attack of vertigo getting up in the morning. जैसे ही मैं सुबह उठा एकदम से सारा कुछ घूम गया, मैंने पकड़ लिया, ठीक हो गया। हाँ, कितनी देर रहा? डॉक्टर साहब बहुत देर रहा। बहुत देर नहीं रहा। Spinning did not last for long. Spinning, asked him specifically how long the spinning lasted. From 30 to 30 seconds, maximum 1 minute. By definition, maximum 3 minutes. If it lasts more than 3 minutes, it is not VERTIGO. It is central positional vertigo, but if he is more than 50 years age, cerebellum, proculus, yeah, देखो. So this is, what is this? So that means you will be attack of vertigo. And now the patient, when she got up, moved, ampulla moved, 100 to 10, 100 and interpreted in last vertigo, spinning. Okay? Spinning occurring with change in position of head. Now, patient got frightened, again lie down. Again the particles will move, but now in the opposite direction. Again she will have vertigo. Now, somehow she got up from bed and was going to room, and then on bending, particles will move on. While working in kitchen, she will extend her chin to get something, again particles will move. So that means there will be recurrent attacks of vertigo, recurrent attacks of spinning, occurring with change in position of head with relation to gravity. जब gravity के साथ particle move हो रहे हैं तब, अगर आप बैठे हुए हो और ऐसे सिर हिलाया, gravity is not acting on your semicircular canals. If you are having vertigo at that time, it is not. Every positional vertigo is not. These are small nuances which we usually do not disclose because they're how you pick the things up is like this. So by definition, recurrent attacks of vertigo occurring with change in position of head with relation to gravity, lasting less than 3 minutes, ceasing spontaneously, that is BPP, benign, jam thoda deri, dry, benign, paroxysmal positional vertigo. Positional samajh aa gaya, vertigo samajh. What is paroxysmal? Now the particles have entered this. Patient is lying in Manipur. There is no other neurologist in the near vicinity. So what will happen to that patient? The otologists, they have their calcium carbonate crystals, they have to die their own death. Patient will recover within 2-3 weeks. But चोर की मां वहीं बैठी है. Root cause, अगर दोबारा झटका लगा, अगर फिर वो बगैर पिल्लों के सो रहा है, अगर फिर वो एक साइड पे सो रहा है, अगर फिर कुछ हुआ, any instigating factor, एक बार shoulder dislocation होगी, दोबारा होगी, unless until you take precautions. तो ये बार होएगा. There will be paroxysms of 5, 7, 10 days of vertigo with disease-free period. Again paroxysm, again disease-free period. So repeated attacks of spinning occurring with change in position of head with relation to gravity, lasting less than 3 minutes, ceasing spontaneously. That is benign paroxysmal positional vertigo. किसी को नहीं समझ आई तब की बात में तो आगे चल. पूछो भाई, वो सिर्फ उठ के बैठी कुछ और पढ़ी जाती, बाहर जाके पढ़ना अपने लाइब्रेरी में. मैं कुछ नहीं बोलूंगा यार, जाओ बेचारी कोई बैठी है, ऐसे बैठा है. हाँ जी.
Otoconia है, they enter from common crust.
Yes, that is the one. See, is a horizontal semicircular canal. Semicircular canal because it is semicircular. So it is, this tube is divided into two parts, highly unequal. There is lies cupula, and it completely bisects the canal into a shorter part which it opens into utricle, and the long crust which opens either into utricle from the other end, that is non-ampullary end. This is non-ampullary end, this is ampullary end, or it will open into the common crust. So particles, even if they enter from this side, this part is so small that they usually tend to self-clear. So they will enter only through the common crust. And see, now if you take note of this, now comes the anatomy. This is the non-ampullary end of posterior semicircular canal. It is 40 degrees below the horizontal in sitting position. Now patient is sitting. It is facing me. But its non-ampullary end is 40 degrees. That means it is the most dependent part while sitting position. Yes. Of the labyrinth. Similarly, when patient lies, now it is facing upward. Again, the posterior canal is the most dependent part. So that means particles, even when they enter the common crust, they will immediately enter the posterior canal. Maximum chances. So posterior canal BPPV is commonest, accounting for 60-70%. Horizontal canal by name is horizontal. So particles do have, suppose you are lying on this side, particles do have chance to enter here. 20 to 30% cases all of this. Now this is, and superior canal is against the gravity. Its other name is superior, not anterior. So that means particles, if they enter here, when the patient gets up, they will self-clear themselves, even if they enter anterior canal. So anterior canal is the rarest, around 1 to 2% of cases. If you happen to encounter that downbeat nystagmus or anterior canal BPPV, always question yourself, am I right? मैं 1 मिनट का ब्रेक में कहानी छोटी सी सुनाऊं. 2019 a lady came to me, BPP, positional vertigo, getting up, lying down, this, that. I did the Dixalpine downbeat nystagmus, I felt the anterior canal BPP, I did that Jacobiano maneuver and the patient got corrected, and I wrote on the prescription slip everything I charged, whatever I charged, and then when she was going back, I wrote down advised MRI brain with CV junction. एक MRI करवा लेना. बोली वो क्यों? तेरे से पहले मैंने 5-6 पेशेंट देखे डाउनबीट के, कोई मुझसे ठीक नहीं हुआ, तू कैसे हो गया? बड़ा अजीब डॉक्टर है बोलती. मैं ठीक हो गई, तू बोल रहा है एमआरआई करवा लेना. बहुत जची नहीं मेरे को, ठीक कैसे हो गई एकदम से? एंटीरियर कनाल मुझे नहीं लगता कि होती भी है. बात आई नहीं होगी. 2020 कोरोना लगा हुआ, she came back again with complaints of positional vertigo. I did the VNG, nothing was found. I said again got get an MRI done, but yeah, जब दोबारा तकलीफ होगी तब. Again after 8 months she came back to me. कि भाई दोबारा फिर हुई. मैंने फिर किया 1.5 साल में, फिर डाउनवेट. अरे डाउनवेट रिपीटेड एंटीरियर कैनाल, मैंने तो कभी पढ़ा नहीं लिटरेचर में. मैंने पूरा VNG करा, उससे पहले नहीं करता था BPPV का. तो भाई इनएक्यूरेट टेस्ट. अब क्या है सुनो. Here the particles entered the anterior canal, downbeat nystagmus. When she got up, particles moved in the opposite direction. There should be upbeat nystagmus. लेकिन उस पेशेंट में लेटने के भी डाउनबीट, खड़े होने के भी डाउनबीट. That means it is not beat. मैं क्या बोल रहा हूँ, छोटे छोटे माइनसेस यहाँ से तो ये क्या, मैंने कहा हमारी कराई की माना फोरामन मैग्नम मेनिंजियोमा लेके बैठी थी, 2 सेंटीमीटर का. न्यूरोलॉजी इंडिया में पब्लिश हुआ थी. न्यूरोलॉजी फोरामन मैग्नम मेनिंजियोमा प्रेजेंटिंग एज बीपीपी. मैं क्या कहना चाहता हूँ, फ्लोकुलस फोकस कर रहा था वो सारी कदम के, इसलिए डाउनबीट nystagmus. तो एंटीरियर कैनाल बीपीपीवी इज always carry home point is anterior canal DPTV is always to be taken cautious. ठीक है? So यहाँ पे हमने कितनी सारी बातें कर ली हैं. Etiology we have already done. Bas, everything is written in the available in literature. सब कुछ खोलो भयंकर पड़ा है, लेकिन पैथोफिजियोलॉजी, अब एक चीज है, एक चीज हम भूल गए. सिर्फ एक, चाहे इतना सा पढ़ के जाना, लेकिन वो समझ आ जाए, यू कैन बिल्ड ऑन दैट. मेरी आदत थी जब ऐसे 8-10 साल पहले मैं गीता का ना रोज एक श्लोक पढ़ता था. जब पाठ करने लगता तो सुबह में, तो एक बार मैंने पढ़ा तो कृष्ण ने क्या श्लोक आया कि अर्जुन ने कृष्ण से पूछा कि जो तेरी भक्ति में लगे लेकिन अपने पथ से भटक गए उनका क्या होगा. पढ़ते पढ़ते मेरी आंख में आंसू आ गया कि हम भी वही धोबी के कुत्ते हैं, ना इधर के ना उधर के. तो लेकिन क्या हुआ कि जब कृष्ण भगवान का आंसर पढ़ा तो मजा आ गया. बोला मेरे पथ पे बढ़ाया गया एक भी कदम व्यर्थ नहीं जाता. दैट विल बी एडेड अपॉन एंड इन थ्रू वन जन्म अदर जन्म, तो वो ऐड होता जाएगा और फिर एक जन्म पे तुम ऐसे घर में जन्म लोगे जहां तुम दिन दुनिया से अलग होगे और सिर्फ मेरे रास्ते लग जाओगे. मजा आ गया पढ़ के. तो मैं इसलिए याद आ गया मुझे कि आप चाहे 2 चीज सीख के जाना बेसिक, उस पे बिल्डअप होएगा. पोटे का सारे अच्छा अपबीट पोस्टीरियर कनाल घोटा लगाते जाओ, कल को कुछ और निकलेगा. सो ट्राई टू अंडरस्टैंड व्हाट आई एम ट्राइंग टू. ये मुझे किसी ने नहीं सिखाया, तो मैंने खुद सीखा था. जब तक भागा के 3 साल लगातार डेली 8 घंटे मिनिमम 2013 से पहले. ये once the particles are dislodged, they will fall into the canal. अब they enter into the canal through the common crus and they are lying here. They are lying within the tube of the canal. That is known as canal lithiasis. But if they get attached to this cupula, which is sticky material, they will make the cupula heavy. That is known as cupulolithiasis. But इससे ज़्यादा मैं अभी बात नहीं करूँगा, otherwise it will be like confusing. ये हम बात कर चुके. अभी इनकी क्लासिकल कंप्लेंट्स, ये हम बात कर चुके. फर्स्ट अटैक ऑन vertigo in episodes triggered by changes in head position, taking turns, lying down, getting up. मैं जब बेड से उठती हूँ, लेटती हूँ, साइड लेती हूँ, झुकती हूँ, चीज उठाती हूँ, तब चलता है. बैठे बैठे ऐसे करने से चलता है. वो भी seizing spontaneously leapers on placing the head in the focal position. डायग्नोज कैसे करते हैं? चलिए हम डीपीटीवी क्या होती है, कौन सी कनाल्स ज्यादा इन्वॉल्व होती हैं, क्यों हो सकती है, यहां तक किसी को कोई कंफ्यूजन है तो पूछो. पूछिए सवाल यार. भाई अपन लेटे हुए थे, पार्टिकल केम थ्रू द कॉमन क्रस इन द पोस्टीरियर कनाल. आपके पास पेशेंट आएगा, व्हाट विल ही से? डॉक्टर साहब चक्कर आते हैं. आप बोलोगे कैसा चक्कर आता है? मैडम ने बताया, सबसे पहला सवाल जो मैडम ने बताया, चक्कर का मतलब क्या है? व्हाट इज पेशेंट ट्राइंग टू कन्वे? चीजें घूमती हैं कान या कान के सेंट्रल कनेक्शन से, ईयर और सेंट्रल कनेक्शन. बैलेंस बिगड़ता है, इम्बैलेंस. इट कैन बी ईयर, vestibulospinal reflexes, it can be cerebellum, it can be basal ganglia, it can be so many neurological causes or ईयर। आंखों का अंधेरा आता है, नहीं नहीं मेरा बैलेंस नहीं बिगड़ता, मैं घूमता नहीं है, आंखों का अंधेरा आता है। ब्लैकआउट, मेडिकल कॉजेस, हाइपोग्लाइसीमिया, एनीमिया, so many postural hypotension, other causes. So coming back to our, so first was there, sir patient बोला चक्कर आते हैं, अच्छा कहाँ कैसे आते हैं सर? जब भी मैं उठती हूँ लेटती हूँ, इतने दिन हो गए इधर झुकती हूँ, पासा लेती हूँ, साइड लेती हूँ, ये ठीक है जी। आपको कितनी देर रहते हैं? They should remain for spinning should remain for more less than 30. अब आपके दिमाग में जब कंसेप्ट है तो आपको पता चलेगा कि यार वो बोलेगी कोई बहुत देर मेरे को इतनी देर मेरा, अरे मैं तेरा दिन खराब हो रहा था उल्टी आ रही, ये नहीं पूछ रहा, ये पूछ रहा हूँ स्पिनिंग के लिए। Once you decided it is BPPV, now proceed with the diagnostic test. So diagnostic tests for positional vertigo, the most common is posterior canal. तो हम पोस्टीरियर कैनाल का डायग्नोस्टिक टेस्ट की बात करेंगे, ठीक है। द गोल्ड स्टैंडर्ड टेस्ट इज डिक्स साल्पाइट टेस्ट, डिक्स एंड हाल्पाइट। कोई बताएगा डिक्स साल्पाइट टेस्ट कैसे करते हैं? ये तो यार सभी को मालूम है, आजा 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 आजा, यू विल नेवर फॉरगेट दिस सेशन। हम बता yes. ये दिस इज पेशेंट सिटिंग इन अपराइट पोजीशन। हाँ जी कर बताइए। No, I have put the beads on the right, so make it right. So you will move the head. हाँ करिए करिए करिए।
Tilt the head of the patient to 50 degrees towards the left side, and we will make the patient to lie down immediately. And we will extend the head behind the table.
Okay.
30 degrees.
Very good. So what do you expect? पहले तो उनकी बात पे आते हैं, बहुत अच्छा बोला बच्चे ने कि 15 डिग्रीज है इधर, 15 डिग्रीज क्यों करोगे? The three semicircular canals have right angles to each other. If this is anterior, this is posterior, they should be 180 degrees each other, but it is anterolateral and posterior is posterolateral, 45 degrees each. That is why they make an angle of 90 degrees each. And they make 90 degrees, these vertical canals make an angle of 90 degrees with the horizontal. So, my dear, you are not going to move at 15 degrees, you are going to move at 45 degrees. Why? Because this was posterolateral canal. When you will ask the patient to lie down, it will be 45 degrees only vertical to the ground. Effect of gravity will not be that much. So by moving the head of the patient, please back कीजिए. By moving the head 45 degrees to right, I have made the posterolateral canal exactly posterior, so that when now the patient moves back, there will be maximum effect of gravity. The posterior canal will be at 90 degrees to the ground, so that the maximum effect of gravity will be on the autolus, so that they will move maximally, so that drag will be maximal, so that nystagmus will be maximal, so that vertigo will be maximal. Okay, so it is not 15 degrees, it is 45 degrees. Otherwise, you will get pseudo bilateral BPPV or no result at all. 45 degrees, remember 45, 45. 45, 45. 45 degrees below, hanging below. What is the problem in hanging at 45 degrees? Particles will not settle here, but they will come here. The greater the distance they will travel, the greater disturbance you will have. Sir, I can demonstrate it. I will show you the videos. I am going to show a lot of videos if time permits. So, but I just want to make it understand that what is happening in. If we can understand that, videos of videos. So, Done. Now let us have a look at few videos of this sample test. This. So I have moved his head 45 degrees to left. I am taking him back. Head extended. Can you see? Upbeat nystagmus. Actually, you can appreciate it. There are number of videos on YouTube. We are stimulating posterior canal, which is a vertical canal. So that means nystagmus has to be vertical. Done? And then it was not posterior canal, it was posterior lateral canal. That is why it just the whole axis. So that means there will be torsional nystagmus also. So there has to be torsional and vertical upbeat nystagmus. So here in this video, again I will play 45 degrees to left, taken back 45 degrees. You see upbeat nystagmus. For those who are first year postgraduate students, nystagmus by convention, direction of nystagmus towards quick component. It was moving quickly upwards, so it was upbeat nystagmus. If it is upbeat nystagmus, लिख के रख लो, it is posterior. It has to be posterior. Downbeat nystagmus, either flocculus, cerebellum here, या anterior. Torsional component दिखाते हैं बाद में. आज है ना एक पेशेंट recent day before yesterday संगरूर से पेशेंट का फोन आया, डॉक्टर है सुनाम में ऑर्थोपेडिशियन. डॉक्टर साहब मेरे को बीपी हो गया. तो मैं कहा जी बताइए. मैंने वो YouTube से देख के मैन्यूवर कर दिया अपने. अगर किस साइड का ना हुई बस कंफ्यूज भी मैंने किस साइड का. अरे भाई तूने टॉर्जनल कंपोनेंट खुद नहीं देखा तो कहां का करता है. This is upbeat nystagmus. Can you see? Which component is towards up? Now have a look at this patient. Her head was towards right and lie down. And you see, now it is eye is moving. Rotatory movement, torsional component. Can you see? Torsional. So this catch hold of one vein. How will you see catch hold of one vein or one vessel? See in which direction it is going. So it was moving towards this direction. That means towards right here. Direction of the torsional component tells you the ear. Whatever the test. You ask the patient to lie down straight. I will show you. Patient developed torsional. Now you haven't done this already. Patient lies straight. But the directional component torsional component was this. That means left ear. It was upbeat. Left posterior is involved. Diagnosis is not by the test. Diagnosis is by the direction of nystagmus. Nystagmus tells you the ear and the canal involved, not the test. So this was torsional component. I will look at it again and then we will move to the next. Is it okay? Now, upbeat and torsional both combined. Right here. Torsional and upbeat combined. So I am testing the right ear. So this is right posterior canal PVP. So always do the disc sulfide. And patient says, when I get up from the right or lie down on the right side, I develop vertigo, spinning for 30-40 seconds. I did the disc sulfide test. There was torsional and upbeat nystagmus, which means right posterior canal. Have a look at the image. Okay? Chalo. Have a look at this patient. Again, right ear is being tested. Wait. कोई चक्कर नहीं है, नहीं आया। बहुत मिनिमल torsional component is coming, but wait, hurry. Torsional, can you see? Right ear is being tested. So this torsional component is moving towards right ear, and right ear I was testing. So this is right ear is involved, and upbeat. So that means torsional upbeat. That means right posterior canal. It manifested fully after 20 seconds. So the next carry home point is, आपने 6 साल पहले किया और पेशेंट को निस्टैग्मस नहीं आया, तभी 5 सेकंड में खड़ा कर दिया, बिट्टे हूं, गलत करा, वेट फॉर 30 seconds. ये carry home point है. You must wait for minimum of 30 seconds before denouncing it. So इसमें क्यों लेगा? कोई आंसर देगा? बोल भाई. अरे कल ही वर्टिगो प्रैक्टिस कर ले, इतनी चलेगी, पूछो मत. हिंदुस्तान के डॉक्टर दिन में 3 लाख 4 लाख कमाता है, मैं नाम नहीं लूंगा, वर्टिगो दिन का 4 लाख कमाता है और सभी काम उसके बच्चे करते हैं, वो बैठे डॉक्टर साहब आराम से करते हैं. बता लेट क्यों आया भाई? कुदरत ने लिख के नहीं भेजा कि सभी का बीपी 120/80 नॉर्मल होता है. मेरा हार्ट रेट 51 है. जब मैं 10 किलोमीटर भागता था ना, तब मेरा वो था, स्टेफीग्राफ का 42 था, बोरिस बेकर का 38 था नॉर्मल. प्लेयर्स का, एथलीट्स का कम होता है ना, बेगर टोन बड़ी होती है, तो वो भी नॉर्मल है उसके लिए. तो हर कैनाल का कर्वेचर 45 ही हो गया, ऐसा नहीं है, किसी का कम किसी का ज्यादा. तो वो कर्वेचर से निकलते मोमेंटम बिल्ड करते उसको टाइम लगा होता है. अगर मैं थोड़ा सा इंकुलेशन इधर उधर करूं तो ज्यादा जल्दी आ जाएगा. ऐसे बोल रहा हूं, हर चीज पे दिमाग में क्यों आना चाहिए ना? क्यों ले रहा है? यही कारण हो सकता है, मुझे तो यही लगता है. ठीक है, चलिए. ब्यूटीफुल. नाउ सी, टिल नाउ मैंने निस्टैग्मस को पढ़ाया नहीं. हाउ निस्टैग्मस इज जनरेटेड. अरे भाई, कंजेनिटल निस्टैग्मस देखा किसी का? यू हैव बोथ क्विक एंड फास्ट फेजेस. यहां पे क्या था? स्लो एंड क्विक फेज. वेस्टिबुलर निस्टैग्मस इज कैरेक्टराइज्ड बाय स्लो एंड क्विक फेज. अगर केले स्लो फेज है या क्विक फेजेस हैं तो वो वेस्टिबुलर सिस्टम के निस्टैग्मस नहीं है, वो सेंट्रल नर्वस सिस्टम के. छोड़िए, अभी उसका हमने जनरेशन को पढ़ाई, हम उस गए नहीं. चलिए, हो गया. अब व्हाट आर द कैरेक्टरिस्टिक्स ऑफ निस्टैग्मस इन डिस्क. अभी डिस्क में चल रहा है, ऐसे 18 महीने हुए सर डायग्नोस्टिक. अभी हम डिस्क साल पे चल रहे हैं भैया. लेकिन डिस्क में होने वाली बात नहीं है. 60% मरीज आप पोस्टीरियर कैनाल के ठीक कर दोगे, सारे शहर में चर्चा हो जाएगा. वो डॉक्टर चक्कर का इलाज करता है. फिर तेरे पास उल्टे सीधे भी आएंगे, तो सिर पकड़ के बैठ जाएंगे, थोड़ा ठीक नहीं हो रहा, क्या करूं. अब मैं भी जब शुरू में 2 या 13 से पहले पोस्टीरियर कैनाल वाले वो हॉरिजॉन्टल निस्टैग्मस होती थी, मैं उसका अपने करे जा रहा, पता ही नहीं चल रहा ये तो लेटरल कैनाल इन्वॉल्व है. तब तक खुद है बेटू. चलिए, अब क्या है, अब सुनिए. आपने पेशेंट को 45 डिग्री इधर करा, ये पोस्टीरियर हो गई, लिटाया, पार्टिकल्स मूव करे, बट आपने सर की बात, इट शुड बी डन विद द स्पीड. इफ यू डू इट वेरी स्लोली, पेशेंट को कुछ ना हो तो वो धीरे धीरे मूव करेंगे. दे विल नॉट क्रिएट ड्रैग, नो nystagmus will be available. कौन बात कर रहा था कि आप पूछ रहे कौन बात कर रहा था कि भैया तो nystagmus ना हो और वर्टाइगो हो, तो ऐसे मरीज नहीं होगा. If you want to elicit nystagmus, do it first. क्या बात करते हैं, करो ये कब से करो. Speed should be different. Which should be done quickly. ऐसा नहीं. अभी मैं सीमाउंट मेन्यू को दिखाऊंगा, अगर आप 1 सेकंड के अंदर अंदर नहीं कर सकते तो वो फेलियर है. ये इसमें पानी है, अभी सीमाउंट के दौरान ही दिखाऊंगा, पानी गिरा नहीं, और अगर इसको धीरे धीरे करूंगा तो यहीं पे गिर जाएगा. तो ये वो क्यों मैटर करता है इसमें अभी हम आएंगे. तो सर जब हमने इसको 45 करा, पोस्टीरियर करा, ये धीरे धीरे इधर पार्टिकल मूव करने लगे. बट बिफोर दे स्टार्ट गेटिंग मूविंग, इनर्शिया है पार्टिकल्स का अपना. दे विल टेक टाइम टू मूव, स्टार्ट मूविंग. 1 to 3 seconds is the latency before nystagmus occurs. Latency 1 to 3 seconds. Then they will move through the endolymph. They will gravity will affect on them. They will gather momentum. Nystagmus will start increasing. Then they will reach their new destination. Their speed will decrease. The nystagmus will decrease. Crescendo, decrescendo pattern you just noted on those all patients. धीरे धीरे शुरू हुआ, तेज हुआ, धीरे धीरे बंद. Crescendo, decrescendo pattern lasts for less than 2 minutes because it is the time taken by them to reach new destination. Fatigability. अगर तुम 5-7 बार आओ, तू भी कर, सभी करके देखो, तो the mass of autolymph ਲੱਡੂ ਜਿਹੜਾ ਬਣਿਆ ਸੀ ਨਾ, ਉਹ ਭੁਰ ਜਾਂਦਾ ਬੂੰਦੀ ਵਿੱਚ. So though that the particles get disintegrated and they will not be able to cause drag. So just ask the patient to rest for some time. Again the clot will form again. Beating towards undermovement factor, ये वो आप इसमें clockwise right clockwise में मत पढ़ो. एक सिंपल बात बताइए, अपर पोल ऑफ आई बॉल जिधर को जा रहा है वो कान इम्पोर्टेंट है. दैट इज ओके. अब भाई मैं इनमें नहीं जाऊंगा, मैं इसमें नहीं जाऊंगा कि ये nystagmus भी अगर आपने इस वक्त इधर को देखा तो nystagmus आपकी बढ़ जाएगी. अगर इधर को देखा पेशेंट ने तो टॉर्शनल कंपोनेंट ज्यादा होगा. इस आंख में टॉर्शनल कंपोनेंट ज्यादा है, इसमें ये इधर सुपीरियर ऑब्लिक काम करता है, इधर इंफीरियर रेक्टस काम करता है. क्यों करता है मैं उसके डिटेल में नहीं जाऊंगा, नहीं तो पीपल विल गेट डिसऑर्डर. क्या है मैंने भी नहीं पता. शुरू में 2 मरीज ठीक करके पैसे कमाना अपना मेन मकसद था भाई. बढ़िया मरीज खुश हो गया, 4 बंदों ने दुआएं दी, 2 और मरीज लेके आया, नाम बनने लगा. वो नाम बनता था वो अपने किट देता है, वो किट वो बाद में जब फंसते तब फंसते, तो पहले किट तो ले. ठीक है. अब ये नया लेसन. नाउ आई हैव टर्न हर हेड टुवर्ड्स राइट एंड आई एम टेकिंग हर बैक. ध्यान से देखिएगा. अरे ये क्या हो रहा है, तो कोई कंपोनेंट नीचे को आया. ये देखो, ये देखा कोई कंपोनेंट नीचे को आ रहा है. दिस इज डाउनवर्ड nystagmus. दैट मींस anterior canal is involved. Which side? Canals behave in pairs. When you are moving the canal, राइट को टर्न करा था, राइट को वापस लेके गए, किसी पेशेंट का लगा देते. राइट को टर्न करा, राइट पे लेके गए, तो यहाँ अगर ये कैनाल इन्वॉल्व होती तो अपबीट आती, ये डाउनबीट थी, तो इधर की एंटीरियर लेफ्ट एंटीरियर ने इसके साथ केयर करा था, तो लेफ्ट एंटीरियर कैनाल. इट इज नॉट द राइट एंटीरियर. right posterior and left anterior form appear. If it is upbeat nystagmus on this sulfide right, it is right posterior. If it is downbeat nystagmus, it is left anterior. So this sulfide is not for posterior canal, it is for both the canals. Right of the same side, left of the and posterior of the same side and anterior of the opposite side, because they form here. Now my question is, suppose the particles, suppose in this patient, if I do the, भैया बता आजा आजा आजा, बहुत बढ़िया बंदा है, पता मेरे को कुछ तो इंटरेस्ट ले रहा है बैठ के। कहाँ गए हो? कहाँ के हो? Which place you belong to? Andhra Pradesh, Vijayawada. In Visakhapatnam we have a very good friend, Pradeep Bundari. Base of Skull Surgeon. Pradeep Bundari. So, now next is, suppose now the particles are in the posterior canal of right side, but what we are going to test is, see, you have a look here. Now I am going to test this posterior canal. We moved his head to 45 degrees to left. Left posterior lateral canal has become left posterior. Now we move the head towards this side. Here there were no particles, no upbeat nystagmus. What will happen to that side? Actually, this side will be horizontally placed. It will be parallel to the ground. There will be no nystagmus. So Dick's sulfide test is either for the posterior canal of the same side or the anterior canal of the opposite side. ये कैरी हम पढ़ते हैं, ये बात निचोड़ है जो हमने पढ़ा उसका. Dick's sulfide test is for both canals of the posterior canal of the same side, anterior canal of the opposite. Got it? और तेरे लिए 45 posterior canal of the same side, anterior canal of the opposite side. Upbeat nystagmus to this side, downbeat to anterior canal. Okay? Torsional components tells you the direction of the which ear is in. समझ लगी? These are the, ये इसको नहीं समझ, लिख लेना, नहीं समझ, चलिए. So this video was just to show that Dick's sulfide test is to test. It is very easy for me to impress you with a lot of videos. Each video gives you something which will आपके प्रैक्टिस में ले भाई ध्यान दो. सीधा लेटा है बंदा, सीधा लेटा हुआ है. अब मैंने इसका हवा रुक गया. Torsional upbeat nystagmus. Torsional upbeat nystagmus. Can you see? Torsional component is towards right side. I will replay. What I have done is, patient was lying supine. I just moved his head to right. Not Dick's sulfide, because he had taken below. So that means his head was like this in flexion, not in extension. I moved his head towards right side. It is not Dick's sulfide test. It is supine roll test. Right lateral position of the supine roll test. Again, have a look at it. Okay. So this is right lateral position is lying supine. After few seconds of wait, torsional upbeat nystagmus. It is the nystagmus, not the test, which decides which ear and which canal. ठीक है जी? कोई भी मैनिपुलेशन सीधा ही लेटाया आपने तो उसको ये आया तो वो राइट पोस्टीरियर कनाल डिफिकल्टी है भैया. ठीक है? टेस्ट ठीक है, बट डोंट बी डॉगमेटिक कि मैंने जो बोला वही है, ऐसा नहीं होता है. एक और देखो, इसको सीधा लिटा रहा हूं, सिंपल बैठे से सीधा, सिट टू सुपाइन पोजीशन में। देखो स्लो मोशन में आइए, स्लो मोशन में करके दिखा रहा हूं। सीधा लिटाया है, कुछ नहीं करा, पिल्लो पे लिटाया है, नो एक्सटेंशन। ये देखा अपबीट में स्टैगमस, यानी कि अप्रिशिएट, अपबीट में स्टैगमस आई, हल्का सा टॉर्शनल कंपोनेंट राइट को। यहां पे देखोगे तो आपको टॉर्शनल कंपोनेंट देखने के लिए सबसे बढ़िया चीज है एक ब्रेन को पकड़ो, वो आपको बताएगी किधर को बोलना है। So this is these two videos try to show that it is direction of the nystagmus, not the just which decides which canal of which is. लेकिन ये commonly नहीं होता है। Common things are commonly, that is why they are common. Common साल बाइक में ही आएगा, बट गधे और घोड़े में फर्क क्या होगा भाई? हाउ विल यू डिफरेंशिएट योरसेल्फ फ्रॉम द अदर्स? आपको छोटी चीज भी पकड़ना आना चाहिए, यही है। आप गलतियां करके सीखोगे, हमने तो ऐसे ही सीखा आफ्टर बर्निंग आवर हैंड्स, बट दीज वीडियोस जस्ट कन्वे अ मैसेज, इसलिए ये देखो भाई, अब आई एम टेस्टिंग हिज राइट पोस्टीरियर कैनाल फर्स्ट। राइट पोस्टीरियर कैनाल, can you see torsional component towards right, torsional upbeat nystagmus? So this is right posterior canal. Now I am checking for downbeat nystagmus when the patient gets up. चलिए, you skip this for the time being, वो वीडियो फास्ट नहीं हो सकता इसमें। चलिए, now we check the left side. Now this is 45, 45. Check the left side. Upbeat torsion. Both sides are positive. So he has torsional upbeat nystagmus on both sides. This is bilateral involvement of posterior canals. आपकी इमरजेंसी में जब भी आपको बुलाया जाए, always check all the canals. Multi-canal involvement is very common in post-traumatic cases. Why? Head injury, sudden blow, pastry, otoliths, boom, going entering the various canals. Always check all the canals and both sides. So this is bilateral. Carry home messages. Always check both. Even if when you check the first, it is positive. हाँ ठीक हो गया, कर दिया, अप्लाई कर दिया मरीज। फिर आया बोलने बाद डॉक्टर साहब चक्कर फिर भी आ रहा। दूसरी साइड चेक ही नहीं करी हमने। You must check both these sides. इसको भी देखो, राइट साइड। मैं इसमें दिखाता हूं ताकि मैं इसको फॉरवर्ड कर सकूं। राइट पोस्टीरियर कैनाल, हैव अ लुक हियर। देखा अप्रिशिएट मुश्किल हो रहा है। Wanted to say that can you see torsional upbeat nystagmus? Right posterior canal is gone. Also notice this gap in the post-traumatic phase. Patient is sitting now. We have moved his head towards left now and is taking him back. Now discs are applied on the left side. Yes. Again you have it. Okay? Upbeat. Beautiful. Crescendo, decrescendo, crescendo. Still it is. Now it is decrescendo. Typical bilateral posterior canal involvement. That was one test of diagnosing posterior canal, that is Dixon. That is one Dix-Salpike test only. Now what is the other method? आजा भाई कहाँ गया? आजा तू पिछली सीट पे बाहर मत निकल जाना, पीछे जा रहा है। See, now I show you something else. Now this patient this is posterior canal is involved. The Dix-Salpike test is moving like this and like this. Now, if I have a look here, if I ask the patient to move my head towards left side, not to right side, but to left side. Now, but the canal has become this, posterior lateral canal has become the lateral. If I move my head towards right, it was exactly posterior. Now I moved my head to left, it is exactly lateral. Ask the patient to lie like this. Again it will be parallel, perpendicular to the ground. Again, this is Simon diagnostic maneuver. Simon diagnostic maneuver. You can, if anybody wants to do it, can come here. I will demonstrate. Otherwise, I am going to demonstrate it. So, move my head towards left side. It became exactly lateral. Then ask the patient to lie down. Again, you will have this Simon diagnostic. See, let us. Right posterior canal is being tested. Can you see? Torsional upbeat nystagmus. So this is another test. No worries. You stick to one. मेरे पास वीडियोलॉजी शायद सबसे ज़्यादा 500 केसेस होंगे बीपीपीवी के हिंदुस्तान में सबसे ज़्यादा रिकॉर्डेड एवरीथिंग फ्रॉम 2013। जिस केस में Dix-Salpike फेल हुआ, जिस केस में अप्ले कामयाब नहीं हुआ, उसमें सिमॉन भी कामयाब नहीं। 2 या 3 केस होंगे 500 में से जिनमें सिमॉन कामयाब। तो इसका मतलब ये है कि एक चीज ठीक कर लेने पे डायग्नोसिस में भी समथिंग। हाँ जी सर। नहीं सर, देखिए ये राइट पोस्टीरियर कैनाल है। पेशेंट आपकी ओर पीठ करके बैठा है, मेरी ओर मुंह है। ये राइट पोस्टीरियर कैनाल है। इसका Dix-Salpike आप इसके पीछे खड़े हो, कैसे करोगे? 45 डिग्री इधर कर, ये कैनाल पोस्टीरियर हो गई। अब आपने गिराया, गिर गए पार्टिकल, ये Dix-Salpike है। अब ये आपने पेशेंट का राइट पे साइड पे करा था राइट के लिए, अब मैं सीमॉट करने लगा, अब मैं इसका 45 डिग्री लेफ्ट को करूँगा, ये लेटरल हो गया। अब इसको ऐसे निकाल, एक्चुअली क्या है कि इसको ऐसे निकाल दिया, पेशेंट पार्टिकल यहाँ आ गए, अब यहाँ आ गए, मैं अगर टाइम मिलता है तो मैं दिखाऊंगा सीमॉट मैन्यूवर कैसे 1 सेकंड में ठीक करता है। यहाँ पे आ गया, अब आपने इसको ठीक करना है, पार्टिकल यहाँ आ गए, अगर आप इसको धीरे धीरे पेशेंट को उठा के ऐसे करोगे पार्टिकल इसी दिन में यहीं गिर जाएंगे। तो इसको बिफोर पार्टिकल इधर जा भी पाए, इनर्शिया काम भी कर पाए, 1 सेकंड के अंदर अंदर आपने पेशेंट को उठा के ये वीडियो दिखा सकते टाइम मतलब भी ठीक हुआ, ये 3-4 दिन पहले का पेशेंट। तो इसमें दोनों में बेसिकली फर्क पता क्या, मैं इस पर फिर वही डिटेल में जा रहा, एक मैन्यूवर को पकड़ के ही हम कर रहे हैं तो दूसरे से कोई बहुत ज्यादा एडवांटेज मिलता नहीं। लोग जुम्मा बाइलेटरल लेटर के नाम बीपीपी गार्डियन सोसाइटी में मेरा ओरल प्रेजेंटेशन एक्सेप्ट हुआ, मैंने सभी में ना बाइलेटरल लेटर के नाम आज तक वर्ड में रिकॉर्डेड नहीं है, मेरे पास 6 केस की सीरीज है। मैंने वहां पे दिखाया तो प्रोफेसर जुम्मा ही मेरे को ब्राजील वाला और सारे बैठे थे जुम्मा मैन्यूवर वाला, तो बोलता है तुम जुम्मा मैन्यूवर क्यों नहीं करते? मैं कहा सर मैंने कभी पढ़ा ही नहीं क्या होता है, इसको सामने बोल रहा हूँ मुंह पर इंसान, मैं कहा पढ़ा ही नहीं कभी क्या होता है, कैसे करते हैं, मेरे को जरूरत ही नहीं पड़ी कभी, मुझे बारबेक्यू रोल ही कामयाब रहा है हमेशा। अगर एपोजियोट्रोपिक आ गए तो इन्वर्टेड गुफोनी ने ऑलवेज गिवन मी रिजल्ट्स, मैं भटकूं तो दूसरे जगह पे जाऊं, मैं क्यों मुंह मार करूं? मैंने कोई 20 मिनट सीखने का शौक नहीं है, थ्योरेटिकली पता है, मैं अपने एक से करता हूं, मेरे को उससे मेरी टेक्निक मेरे साथ। तो आप डिक्स आल्फा नहीं करना चाहिए पहले, वो इजी है हमारे लिए करना, पर हम आपको करते हैं। ये मैंने सीमॉट का भी दिखाया, किसी पेशेंट का मैं किसी के बाद वो कर दिया तो तुरंत ठीक हो गया, दिखा दिया। इसको नहीं हम करेंगे, टाइम सेव करेंगे। ट्रीटमेंट क्या होगा प्रोसीजर कैनाल का, कितने सारे मैन्यूवर हैं अपने सीमॉट गैस ब्रांडेड हेल्थ एक्सरसाइजेस, कभी मत कीजिएगा, मरीज पे जुल्म मत कीजिएगा, वो जो एमआर पर्चियां देके जाते हैं वो फाड़ के डिग साहब 5 मिनट इधर लेटो फिर इधर करो फिर इधर करो, उससे अच्छा मरीज से चेक मार दो, वो मत करो। दे आर द वर्स्ट एक्सरसाइजेज यू कैन डू। थॉमस ब्रांडेड भी नहीं करता, उसको भी नहीं मिले थे वहां पे इस बार, थॉमस ये नहीं करता, उसका लॉजिक नहीं है, वो मैं समझाने लगूं तो नहीं करता। अप्लाई मैन्यूवर सबसे कॉमन सबसे इजीली करने वाला वो करते हैं। क्या करना है अब आप चीज देखिएगा, क्या करा हमने, ये पेशेंट है राइट साइड इन्वॉल्व है, हमने राइट को इसको टर्न करा, ये करा, पार्टिकल यहाँ आ गया, ये डिक्स आल्फा मैन्यूवर है, ठीक है जी, राइट का कीपिंग हिज चिन एक्सटेंडेड, मूव हिज हेड 90 डिग्रीज टुवर्ड्स लेफ्ट साइड, पार्टिकल वहीं रहेंगे, उसका रखे तुम ऐसे कर दो तो पार्टिकल कॉमन ब्रश से गिर के, इसको किसी के सिर पे पहना के मैं अभी करके दिखा सकता हूँ इफ समवन वांट्स टू सी। ये इसीलिए बनाया गया कि प्रैक्टिकली करके दिखाया जाए बंदे को कि ऐसा मरीज अपने में ठीक होता है तुरंत। इस पे सीमॉट भी कर सकते हैं, इस पे हॉरिजॉन्टल भी कर सकते हैं। तो अप्लाई मैन्यूवर के 3-4 स्टेप्स में वो यही पे दिखाते हैं जो हम कर रहे हैं और उसका रिजल्ट। अगर कोई प्रैक्टिकली करके देखना चाहता है मॉडल के सिर पे लगाओ और करो एंड यू विल इमीडिएटली गेट ये राइट साइड इज बीइंग टेस्टेड, अब भी राइट प्रोसीजर के नाम ओके, आफ्टर द nystagmus subsides, wait for minimum of 30 seconds. Minimum wait is for 30 seconds. Then keeping the chin extended, move the head 90 degrees. ठीक है, that was the second step of apply. Wait for another 30 seconds. Keeping position of the chin with relation to body like this, move the patient as a log of wood. ये करा, and now move it like this. दोबारा देखो. Head is 45 degrees towards left only. Wait for another 30-40 seconds. Ask the patient to get up. Wait for 30 seconds. Do the flexion. Particles will fall through the common cross in the tube. And then this is the result. Immediately. अरे भाई आपका खुद करने का एवरीबॉडी शुड डू इट. जब मैं 2013 में प्रैक्टिस शुरू करी पूरा डड्डू कलारा डड्डू बन चुका से अगर पंजाबी में कोई किसी ने सुनी तो तब 100 में से 70 मरीज ठीक करते थे, छाले मारते थे, सभी पीपीपी आता था और कुछ डायग्नोज भी नहीं करना आता था. आज मेजॉरिटी पेशेंट रेफरल होते हैं, मुश्किल से 100 में से 5 मरीज आते हैं पीपीपी के साथ. ये पुराने पेशेंट है, ये 2014 में पेशेंट.
हाँ जी, जो लास्ट स्टेप पे हम फ्लेक्शन करेंगे,
हाँ जी
पेशेंट को जो हम उठाएंगे लास्ट उसमें, तो जो फ्लेक्शन है वो इमीडिएट होगी या वो कुछ सेकंड के बाद?
बैठने में यार पहले मैं 30 सेकंड वेट करता था तो उसके बाद फ्लेक्शन करता था. अब कई बार पहले भी करता हूँ. ये क्लियर नहीं है कहीं. अगर मैडम आप कुछ स्टेटमेंट डाल सको.
सर आपका इमीडिएटली जैसे ही उठाते हैं सो फिक्स पोजीशन में टू मेक श्योर इट इज.
हाँ जी,
जैसे लास्ट स्टेप से दिखाना है
पार्टिकल तो गिर जाते हैं. नहीं वो एक्सटेंशन करके रखनी है. फ्लेक्शन इमीडिएटली
फ्लेक्शन करते हैं पेशेंट इज ऑलराइट.
नहीं
उसको एक्सटेंशन करके रखनी कि नहीं, ये लिटरली
किस कहीं नहीं लिखा. ये कहीं नहीं लिखा.
प्रैक्टिकली
ये मैं जहाँ फेल होता हूँ, जिस मरीज में फेल हो जाता हूँ, पहली बार कामयाब नहीं होता, उसमें मैं कर करके देख रहा हूँ आजकल भी. पहले फ्लेक्शन करके और मेरा स्टैंडर्ड प्रोटोकॉल वही है. मैं 30 सेकंड ऐसे रखता हूँ. जैसे मेरे पहले मरीज ठीक होते थे मैं तो वैसे चलूंगा. मैं किसी के चलूंगा. हाँ फ्लेक्शन मैं ऐसे करता हूँ. और अगर पेशेंट पहली बार में नहीं ठीक हुआ फिर दूसरी बार करके देख लेता हूँ. शायद कहीं कुछ और हो पर मुझे कोई रिजल्ट में फर्क नहीं लगा. यहाँ पर ये देखिए right posterior canal is being tested again. Again, upbeat nystagmus. Can you see? So right posterior canal is involved. हमने गॉगल्स उतार दी उसकी. Now we will do the maneuver. ठीक है. कीपिंग द चिन एक्सटेंडेड, मूव द हेड 90 डिग्रीज टुवर्ड्स यू. वेट कीजिए. देखा, हेड शुड नॉट मूव, बॉडी शुड मूव. हेड शुड मूव विद योर हैंड्स. इसको कराना है लेकिन अपने आप में. इस वक्त जब ये करवा रहे हो तो फ्लेक्शन ये गलती करता. पेशेंट को नहीं पता होता बट टू फिक्स पहले तू घूम ले भाई फिर तरह से मैं घुमा. बैठा दिया. देखा अभी भी मैंने कोई एक्सटेंशन करी हुई थी ना. वो 30 सेकंड्स के बाद ही करने की आदत रही है. चलिए अब राइट फ्लेक्शन. देखो जी रिजल्ट. मेरा सबसे जल्दी वाला क्वेश्चन है आपसे था। Torsional upbeat on the left side. Wait for 30 seconds. Move towards opposite side. Wait for 30 seconds. बैठा दिया फ्लैक्शन रिजल्ट सिमॉन डायग्नोस्टिक ये देख लो भाई, ये तो वही है जो हमने करा था, ये तो हमने देखी थी ना। ये देखो टॉर्शनल अपबीट, इसको वेट करना है इस पोजीशन में 1 मिनट के लिए। ये देखो कैसे जाता है पेशेंट। और दैट शुड बी द मूव, और ये इसका रिजल्ट है। इसको तो कर दूं क्या नहीं? So this is Simon diagnostic manual। अब मैं जाते जाते कुछ और दिखा देता हूँ। इस लास्ट चीज that's bricks are by that nystagmus horizontal है। चलो लेकिन लेटरल कनाल खत्म हो गया, पोस्टीरियर शुरू हो गई। एक ही कान में लेटरल और पोस्टीरियर दोनों हैं। चलिए थैंक यू। ऐसा है मैं कभी भी पूरा पीटीपी करवा नहीं पाया मन से। रीजन भी अभी पोस्टीरियर कनाल ही हमने भाग भाग के चढ़ गया, लेटरल कनाल, एंटीरियर कनाल, मल्टी कनाल।
सर अभी हम यही सब बातें
नहीं मैं
उसके लिए हम आपको सुबह से शाम तक सेशन तो उसमें फिर
मैं वैसे बता रहा हूँ कहीं भी एक्चुअली 2 घंटे में कितना करा, बेसिक चीज समझ भी आ जाए बंदे को, अगर समझाना है तो फिर थोड़ा इतना भी करे। पर एक साल बाद एक अपने को आए अच्छे से, ये अच्छे से नहीं मजा।
जहाँ तक किसी में हिस्ट्री से हमें आइडिया लग जाता है कि राइट साइड का होगा या लेफ्ट साइड का।
ये ट्रैप है, ये ट्रैप है, लग जाता है पर ये ट्रैप है। मेरे हर मरीज की हर हिस्ट्री में इस लैपटॉप में 2 उसमें अभी वो भी हैं हार्ड डिस्क। ये लिखा है किस साइड से सोता, वो पिलो लेता था नहीं लेता, कैसा लेता था, उसका स्क्रीन टाइम कितना, वो फास्ट फूड कितना खाता है। मैं हिस्ट्री लगाने में 1.5 घंटा तक लगा देता हूँ। मुझे मैं तो मेडिकल नहीं हूँ, मैं अपनी मस्ती से काम करता हूँ। दूसरे मरीज को 1 मिनट नहीं लगाता, उसको 1.5 घंटा। पर वो ये ट्रैप है, फंस जाते हैं। मतलब इट मे बी राइट, इट इज यूजुअली राइट, बट डोंट गेट बायस्ड बाय इट, डोंट गेट बायस्ड। चेक ऑल द कैनाल्स, ऑल द कैनाल्स, चेक द रिजल्ट्स इमीडिएटली। ये एक्चुअली जो मैंने अभी दिखाया ये क्या था, ये मल्टी कनाल कैसे बनी? ये पहले पोस्टीरियर कनाल थी, मैंने मैन्यूवर करा, उसके बाद पोस्टीरियर तो रही लेटर भी बनी, कुछ पार्टिकल निकल।
So we can discuss all this on the lunch. We request Dr. Vineet and Dr. Rajesh to felicitate Dr. Satya. For the next session, we call our chairpersons, Dr. Diksha and Dr. Ravi. So just another 15-20 minutes and then we will be having the lunch. You will understand better about it, right? And before I hand over the mic to our next speaker, the biodata of next speaker.
So our next speaker is Dr. Sudeep Kaur. She is a senior consultant, ENT, cum senior medical officer, Civil Hospital, Panchkula. Her special area of interest is in endoscopic endonasal PCR, treating vertigo and balance patient using tools like VNG. She has 15 years of experience in diagnosing and treating disorders of the ear, nose and throat, committed to improving patient outcomes through evidence-based medicines and collaborative care. She has various major publications, including schwannoma of nasal septal membranous, myeloplasty versus medial myeloplasty, and laryngoscele, a case report. We welcome you, ma'am.
The topic of my talk is psychogenic disease. I will just use the topic because every consultant, every clinician has a patient of psychogenic disease presents to the OPD. It's a very overall differential. Most frequently what we encounter are structural disorders such as migraine, arthritis. Between 30 to 55% of patients of vertigo and imbalance, they do harbor psychiatric or psychosomatic condition. Yet the traditional neurological workups and we just stop at physical anatomy. We don't think about the panic disorders, borderline depressive disorders, triple P or panic disorders. So international classification of vestibular disease of mind. International classification of vestibular diseases, they have been classified into 3 diseases now. Now every disease in our OPD previously, who had first said no structural disorder, they were put into psychogenic disorder. So let's solve that puzzle. Diseases is divided into psychiatric disorders, structural vestibular disorders, and the functional disease. What actually is functional dizziness? It's a group of disorders in which dizziness persists despite the absence of structural neurological abnormalities. So if we have to define psychogenic vertigo, it is a sense of unsteadiness or dizziness which is not fully explained by organic vestibular damage, but it is often linked to acute or chronic emotional distress. So does psychogenic imply purely psychiatric cause? Various synonyms have been used: functional dizziness, post-postural vertigo, somatoform disorders, chronic subjective dizziness, psychophysiological dizziness, and psychiatric dizziness. Let's just solve this puzzle with the help of this example. Now a female patient, 55-year-old, she comes to the OPD, she says I'm dizzy all the time, every day, and that for over a year. She presents with constant, unremitting dizziness combined with episodic bouts of low sustained vertigo, and she has triggers also, positional triggers, sitting, standing, as well as complex triggers environment. And on top of it, she has a medical history of myocardial infarction, a neovasc, post-traumatic stress disorder, which was managed with escitalopram, confusion. The only clue we have is she was relieved with IV plasma in the emergency department. She says I'm spacey all the time, floor is moving, she feels disconnected from the environment, and when we start investigating, everything is normal. MRI normal, audiology normal, VNG examination normal, environment itself is normal, so the clinician is stuck. Patient is deeply stressed. So what do whatever we say, it's all in your head. Now, is this psychogenic? Let's reframe the psychogenic business and solve this puzzle by these two frames. The evolution of psychogenic business, if we say, in pre-era, in 1980, this term psychogenic business, psychogenic vertigo was coined by Jacob et al. Many patients of anxiety neurosis, they did present with business and they were, that is the time that the psychogenic vertigo term was coined. But in 1986, many patients, they presented with dizziness who had personality traits. They had obsessive compulsive disorders, underlying anxiety, and they were termed into phobic postural vertigo because it used to exacerbate upright posture or vertigo. With progress in 2004, many case series they were started, and many patients were seen who had motion hypersensitivity as well as period triggers, and then they were grouped into chronic subjective dizziness. Now all these led to a lot of confusion. So a common term, persistent postural perceptual dizziness, that is low functional dizziness, it was coined by Ryan Society and WHO in 2017. So now we no longer deal with the diagnosis of exclusion, but we have a distinct clinical entity with a positive criteria. If we have to explain and understand what triple PD means, persistent, why? Because the patient has persistent dizziness, postural, it is increased with upright posture, perceptual, patient perceives it. So this dizziness, persistent, non-vertiginous dizziness, unsteadiness or swaying, which is spread for most of the days, for more than 3 months, is triple PD. And the triggers, postural triggers, it is more severe than in upright posture and it is alleviated when flow. And the motion triggers are patient sits in the car or drives or walks, both way the triggers they act. And there are visual triggers because the patient is visually affected. Now, we cannot separate the labyrinth from the brain. We cannot say it is purely structural disorder or it is purely psychogenic disorder because both are linked. The labyrinth and the limbic system, they are inextricably linked. Up to 50% of dizziness they do involve a psychiatric influence, and 15% of patients are those patients who have dizziness in primary care with psychiatric disorders. So let's understand these with these rates. You can see structural disorders. One ring has psychological disorders and the third ring it shows functional disorders such as triple PD, conversion disorder, dystonia. But there are interactions. I mean, there is a place in the ring where both of the things they coexist. So if you see A, that is a patient with vestibular neuritis, attack here, attack right back. With the passage of time, anxiety disorder developed and A from B turned to C. I explained this better with the help of this video. This patient, she came to our OPD, she was referred to us by psychiatric OPD. She had an intense severe attack of vertigo, followed by limitation of her daily activities. She was so phobic of getting out of bed that she developed the habit of just lying on the bed and she was depressive and hence referred to psychiatric OPD, but she was not improving. So she was sent to EAT OPD. We counseled her, convinced her to get out of bed and see. She is walking, she is not falling, though she had history of fall. She had just phobia. So we convinced her that start walking, get out of the bed and you will be better. Then we did the BMG. What we found was unilateral vestibulopathie. Means underlying this depression had an underlying true structural disorder, unilateral vestibulopathie, hence she was put on vestibular rehab. And this you can see the cataract was also done because she had less of vision, so we had to improve vision. And after about 2 months of treatment, you can see her independently walking out of the OPD, doing her all daily course. This is the magic of rehab and magic of diagnosis, the true diagnosis. So what happened was, there was an acute vestibular event that led to threat perception and fear of losing control, so patient was in bed. That led to high anxiety and hypervigilance and hence psychogenic distress. What happened was maladaptation. Normally when a normal vestibular event happens, maladaptive strategies they develop to short period. Patient stops moving their head. Because of moving their head, vertigo comes. But if these maladaptive strategies they persist for long, incomplete pain compensation occurs and a stage of triple develops. Have you ever noticed most of the patients of PPD they present like this. They have anxiety along the neurologist, as per her say, she said that she was advised to have ultrasound 250 mg for rest of her life, and she's been having that for 18 years. And when I consulted my psychiatrist friend, she said 250 mg is not a dose. It's just over a period of time she develops psychological disorder, and she has these two conversion dystonic episodes, and she has only when there is somebody around. This is not lingering, this is true conversion disorder presenting with dizziness. And now she got follow-up in psychiatric OPD and she's doing much better. Another patient, this is a patient of somatoform disorder. He came to the OPD every time he used to change his complaints. He had tinnitus, earness, and positional distractions. I couldn't find anything. Very next OPD, he said he has dizziness all the time, past 1.5 years. And it used to increase with upright posture, with walking, with driving, with everything. With BNG, we couldn't find anything. Then I made him sit and talk. And then his wife, he elaborated that he had some childhood problem with his father. I referred him to psychiatric OPD. He had somatoform disorder. He's on fluoxetine and he's doing better. So psychiatric temporality matrix, if we have to describe this, psychiatric disorders such as panic disorders, generalized anxiety, they directly cause dizziness. Is why do they directly cause dizziness? Because it's a somatic symptom of a mental state, or a structural vestibular insult such as the episodic attacks or a vestibular neuritis. It leads to anxiety, it leads to disability, and then it converts into or comorbid, that is both the conditions they can affect further hamper the brain compensation and hence lead to functional. This is again a very interesting case. She presented to the OPD with episodic vertigo past 1.5 years. She was on tablet working 16 every 3 years continuously for 1.5 years by her physician. In spite of that, she was having episodic attack with vertigo. So first I told her to stop vertigo because I wanted to examine and I wanted to be sure. She was being treated as mini disease because she had highly sensitive neuroleptic loss and she complained of oral fullness, tinnitus, everything. We stopped her working. She came in acute attack. Now acute attack means asymmetry of urine, so nystagmus test had to be there. She had no findings, no nystagmus, no sensory tinnitus, everything normal, motor competence normal, neurological findings normal. We were perplexed, what is we are doing? Then I made her sit with me and we had a heart-to-heart talk. And she started. She had a problem, her elder sister, her daughter, she had a son who had a abnormality and she was having anxiety due to that. And then she had some problem with her husband underlying. So I referred her to psychiatry OPD and now she's doing better. She was a case of underlying anxiety and depression which had led to dizziness. She had no Meniere's disease at all. So if we have to disentangle this overlap, the structural and the functional disorders as well as the intersection, how do we do it? The pure structural disorders, they will have definite findings, the spontaneous nystagmus or the saccades, the red impulse test or the hearing test, something or the other you will find, but in functional or psychogenic dizziness, these findings will be absent, but there will be obvious dissociation between objective balance test and subjective reports of extreme imbalance. Symptoms they will be triggered by not by complex environment, but those social events and avoidance behaviors and disproportionate behavior. This will be present in functional. And in the intersection, you will be able to find both these findings. So that is how we identify the psychogenic overlay by differentiating both the features. What is the explanation? What is the pathology behind this? See, vestibular system is not, and the brain, they are not separate. The liver and brain, they are connected together. All the impulses from the eyes, from the ear and the proprioception, they go to vestibular nuclei all. Now vestibular nuclei, it gives these inputs to amygdala, limbic system, autonomic centers, and from there the inference they come. So there are direct neuroanatomical states which link the vestibular nuclei to the brainstem's autonomic and limbic network. So these stimuli they affect the balance control, and high stress hormones they can impair the vestibular compensation. So you just can't medicate the ear and from the brain. See, the afferents and efferent, it is the balance between the afferents and efferent because the pathways which are linking the liver to the brain, they are affected. So this neuroanatomical convergence that The cognitive behavior therapy helps reduce stress, foster positive emotional response. Dizziness is real, we have to believe, we have to make the patient believe it is real, it is a hyperactive neurological group, and we have to shift the focus from finding the lesion to retraining the brain. Vestibular desensitization. I mean, what are the vestibular rehab or what vestibular exercise? It is nothing but desensitization. The triggers which trigger dizziness, we have to expose the patient to them, but in gradual increment exposure. And we have to break avoidance. Patients instinctively avoid provocative situations leading to physical decline. So desensitization forces the brain to recalibrate sensory input and abandon those maladaptive strategies. How does pharmacotherapy help? SSRI, they are highly effective for treating and psychiatric associated dizziness. It reduces autonomic arousal and stimulates hypervigilance, fuse maladaptive loop. Dizzy patients, they are highly corticogenate and sensitive to side effects. So we have to start with low dose and then gradually increase the dose. So final takeaway is this maze which we started away. Our 54-year-old with normal scan isn't a diagnostic. Here is a highly treatable network dysfunction. By initiating an SSRI to lower autonomic arousal and engaging in targeted vestibular desensitization, this vicious circle can be broken and we have to validate the symptom, identify the triggers and treat the network, and definitely curing the incurable by recognizing the visual and postural triggers and validating patient's sensory experience, employing interdisciplinary osteopathic care. Clinicians can restore the true balance by embracing this holistic response. Let's restore not just balance, but their life.
Yes, ma'am. So, ma'am, I had a patient. Patient came with this कि मैं ड्यूटी पे गया और 2 घंटे में I'm having this feeling, vague feeling हो रहा है. So I tested, everything was normal. So I said, go to psychiatry OPD, like there must be some other symptom. But patient refused. उसको बहुत काउंसलिंग किया. He said no. I said, go to neurologist. He was ready to go to neurologist, but not psychiatrist.
Absolutely right. This I used to do 3 years back. Now I don't do. Because first the clinician has to believe, then the patient has to believe, then the attendant has to believe, and then the treatment starts. It's a long way. Patients keep suffering for many years before they go to a psychiatrist. You have to give time to the patient. Like sir said, I usually take 1 minute, I go home at 6 o'clock, you go take a patient come back to 2 o'clock. Why? Because if you don't give time, you cannot do it. You have to sit with the patient, talk to the patient, and by I think mostly by second, third visit they come up with your diagnosis. And I don't refer to psychiatrist, I diagnose and make a diagnosis, call my psychiatrist friend, I tell them this is the diagnosis. Then I tell the patient, your brain, there is nothing wrong with your brain. Absolutely fine. You are absolutely fine. It's just that there are some intervals. Some इधर-उधर हो गया, उसको ठीक करना है. That is the only way to make them believe that you are normal. It is just something is going on in the brain. We have to check it. Because second in Manchula must be stuff. So you just can't say go to a psychiatrist. So only way to help them is just make them believe that this is nothing. This is like massive calm. They will treat you and you will be okay.
Yes, ma'am. The same was done. I spent around 1 hour. But the thing is, the educated patient having a good job doesn't want to. I told that it's not even psychiatrist as per se, psychologist. They'll ask you problem history, everything, what we have done in detail. But that taboo doesn't go away very easily. I mean,
it doesn't go away. It doesn't go away. थोड़ा भी सीखना पड़ता है. मेरे जितने इंडियंस के पेशेंट हैं, they refuse to stop escalating. वो खाने से ही नींद आती तो I don't stop. I stop when they are ready. You have to see. ये जो पेशेंट्स होते हैं ना, इनका कोई ना कोई साइकोसोमेटिक कंपोनेंट अंडरलाइन होता है. डिप्रेशन होता है, एंजाइटी होता है, पर्सनालिटी ट्रेट्स होते हैं. You yourself have to believe कि इसको है, accept कराना है, और ये ऐसे ही रिलेट होगा. strong, whatever. कोविड का टाइम चल रहा है, उसके बाद what he has is बैठा है तो छूट गया है, ज़्यादा बड़ा फर्स्ट क्लास है, ड्राफ्टिंग करके आया है, ड्राफ्टिंग जो कर रहा है सिर्फ फर्स्ट क्लास से ड्राफ्टिंग करके आगे अपन छूटने जा रहे हैं, and it's not applied everything, and government not easy, not easy. एक सब ठीक हो गई, एक ठीक हो गई, ठीक नहीं हुई because he had underlined migraine also, migraine treated,
मैं ये नहीं बोला, मैं
चला गया.
आपने वो बोला, मैंने उधर देख लिया. She is not married, वो जो भी है, she is married.
भाई तो कर दिया ना, दो की
लड़की
एक ही
टिपिकल बोलेगी, I came from scooty, I was all right. मैंने स्कूटी को स्टैंड लगाया and then I was swinging. This is vestibular.
You will not find, maybe you will not find anything in DAG, but you have to go by history. Your reflex sir कहते हैं ना, 1.5 to 2 hours you have to spend, you will find a structural disorder. कुछ ना कुछ देखो माइग्रेन तो जरूरी है.
It is very,
सर बहुत इंटरेस्टिंग.
it is very easy to label it as, मैं भी सर को बता रहा था. A patient sent by a cardiologist, उसकी वाइफ ठीक हुई थी. 6 महीने मैंने BMG ठीक, सारे टेस्ट ठीक. बंदा बोलता है कभी उठने बैठने में चक्कर आता है, कभी कभी चलने में मेरे को ऐसा लगता है मैं झूल रहा हूँ. मेरे को लगा यार क्या है, मैंने टेस्ट बिल्कुल ठीक है, साइकियाट्रिस्ट पागल है. मैंने उसको प्रोथाडाइन लिख दिया, नहीं ठीक हुआ. 3 महीने में कभी 30% ठीक है, कभी 10% ठीक है, कभी 50% ठीक है. 2-3 महीने निकल गए. फिर मुझे लगा मोबाइल देखते हैं ये वो माइग्रेन होगा. मैंने उसको ट्रिप्टोमर डाल दिया, मैंने उसको सर्वलिफ्ट डाल दिया, लिखा हुआ यहाँ. मैंने बहुत से बात करा, बोले इस बार्गेनिंग इज प्रॉब्लम, कुछ नहीं साइकेट्री की प्रॉब्लम है. 6 महीने बाद एक दिन पेशेंट खिल गया, डॉक्टर ठीक तो हो नहीं रहा. अब नॉर्मली मुझसे कोई ऐसे बात करे, मैं पर्ची बांटता हूँ, जेब में कागज डालता हूँ, बाहर तक छोड़ के आता हूँ, दोबारा नहीं आना. लेकिन मैंने कहा ये बच्चा 25 साल का लड़का, मैंने कहा ये समथिंग इज रॉन्ग. मैं कौन सा ऐसा कारण है जो मैंने आज तक नहीं सोचा. मैंने बुक्स खोली, स्पाइनोसेरिबेलर एटेक्सिया प्लस वर्टिगो किसमें होता है, एपिसोडिक एटेक्सिया. फिर मैंने कहा बनियों में एपिसोडिक एटेक्सिया कॉमन है दिल्ली के, तो मैंने उसको एपिसोडिक एटेक्सिया 2 के लिए कैल्शियम चैनल जीन म्यूटेशन के लिए टेस्ट भेजा. मैं कहा भाई आ जा करवाते हैं, 25,000 लगे. बोला करवा ले. 1.5 महीने बाद रिपोर्ट आई, बोला नो म्यूटेशन सीन इन कैटना वाले जीन. नीचे लिखा काइंडली नोट, ये वाली म्यूटेशन वैलिन रिप्लेस्ड बाय ग्लूटामिन इज सीन इन KCNA1 जीन पोटेशियम चैनल रिस्पांसिबल फॉर एपिसोडिक एटेक्सिया टाइप 1. मैंने 20 बार रिपोर्ट पढ़ी. मैंने न्यूरोलॉजिस्ट को फोन करा, पागल है बोलते हैं, ऐसा कैसे हो सकता है. जिसको फोन करूं पागल है, रिपोर्ट भेज. मैंने रिपोर्ट ना भेजूं, ये तो केस चलेगा. क्यों? एपिसोडिक एटेक्सिया टाइप 1 इज रिपोर्टेड ओनली इन 6 फैमिलीज ऑफ द वर्ल्ड, 5 इन यूरोप, 6 इन कनाडा, 7th हिंदुस्तान की पहली फैमिली. मेरे सामने पड़ा था, मैंने एसिटाजोलेमाइड डाली, मरीज 3 दिन में रिस्पॉन्ड कर गया. मैंने उसको बुलाया, मैं कहा ये प्रॉब्लम तो 7 साल की उम्र से शुरू हो गई. हाँ डॉक्टर, जब मैं छोटा होता लोटना पोटना खेलता होता सी, मैंने चक्कर आते. मैं कहा तू दस्या नहीं, कहता डॉक्टर तो पूछया नहीं. और डॉक्टर को स्वाब पता है कि वो एपिसोडिक एटेक्सिया में ट्रीट कर रहा है. So I have so with due apology I have burnt my hands many times, इसलिए मुझे डर लगता है. You must do up, जैसे मैडम ने भी बोला ना, साल में उन्होंने बोल दिया कि माइग्रेन, ये माइग्रेन का टिपिकल फीचर है. फिर आफ्टर ट्रैवलिंग जब आप झूल रहे हो तो आप वो तो उनके तो केस में बंदे ने ट्रैवलिंग भी करी, राफ्टिंग भी करी. आम बंदा काम करता है मेरे ज्यादा
नहीं सर, राफ्टिंग का और कई ऐसे जो बट वो जाते हैं मेरा नाम है कि जाना चाहिए, इसकी ट्रिगर हुआ है तो इसको एक्सेप्ट कर और कम हो जाएगा. क्योंकि मैरिड हॉस्पिटल का फर्स्ट माइग्रेन का है. अगर पेशेंट सर वेरी इंटरेस्टिंग तो करते से पहली बार ट्रेन करते हैं तो बाजी की वाइफ कमांड में दिखाया, कुछ नहीं मिला. मैच डेवलपमेंट उसको एमएडीसी में डाला. But it was very interesting, but you have to do that.
Thank you, ma'am, for such an informative session. Now, I would request our chairpersons, Dr. Shaban and Dr. Amit, ma'am, to kindly felicitate our esteemed speaker. Now request Dr. Sheni Bhatia ma'am to kindly felicitate our chair. Thank you. Lunch has been served. We can all proceed.